Hello and welcome to your ultimate guide for your CPCT A exam. My goal today is give you everything that you need to understand the full concepts, master them and walk you through the CPCT A exam with total confidence. In this video we will cover cost behaviour, cost classifications, CVP analysis, income planning, overhead allocation. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website helps you to practice your CPCT. An exam with our practice questions, timed mock exams and study guides. You will find the link in the description below. So let's get started.
Question 1. A PCT collected an ammonia level on a patient and is preparing the specimen for transport. The PCT recalls that ammonia is unstable. Which combination of temperature handling and processing time is appropriate to maintain the validity of the ammonia specimen? Your options are A. Room temperature, test within 4 hours. B. slurry, test within 2 hours. C. EC slurry, test within 15 minutes. D. Frozen at -20 degrees overnight. Which one is it? Pause the video if you need more time. The correct answer is C. Slurry, test within 15 minutes. C is correct because ammonia must be transported on an ice-water slurry and tested within 15 minutes to prevent falsely elevated values. Red blood cell metabolism produces ammonia at room temperature, distorting results rapidly without proper handling. Is wrong because room temperature with a 4-hour window is far too long for ammonia. RBC metabolism continues to produce ammonia in the tube, falsely elevating the result and making the specimen unreliable for clinical use. B is wrong because 2 hours on ice is still too long for ammonia. The standard is 15 minutes from collection to testing, with the ice slurry serving to slow metabolism only briefly during transport to the laboratory bench. D is wrong because frozen overnight is appropriate only for some plasma testing, not for ammonia. The narrow time window in ice handling for ammonia mean delayed processing produces unreliable results regardless of subsequent freezing. Ammonia is one of the most unstable analytes in clinical chemistry. Understanding how to handle it correctly starts with understanding what happens inside the collection tube the moment venipuncture ends. Red blood cells don't stop metabolizing the moment blood is drawn. At room temperature, they continue producing ammonia rapidly enough to push results into a clinically alarming range within 30 minutes, creating a false elevation that can trigger unnecessary intervention. Correct handling requires placing the tube into a true ice-water slurry immediately after filling. Not near ice cubes. Not in a refrigerator. The slurry maintains full contact around the tube surface. From draw to analyzer, the entire window is 15 minutes. Ammonia is often confused with lactic acid, which also travels on ice, but allows a longer processing window. Cold agglutinin specimens follow the opposite rule entirely. They must be kept warm at body temperature. Knowing each analyte's specific requirement is core pre-analytical competency. Ammonia testing only has clinical value if the sample reflects the patient's actual status at the moment of collection. Slurry speed and a 15-minute window are non-negotiable. Question 2. A PCT collects a routine specimen and labels the tubes at the bedside. The PCT recalls that 2 specific identifiers must appear on each tube. Which combination of 2 identifiers is the standard for tube labels under CLSI and Joint Commission rules in routine practice? Your options are A. Bed location and shift handoff time. B. Room number and admission date. C. Diagnosis and provider name. D. Patient name and date of birth. Take a second. Which answer would you pick? The correct answer is D. Patient name and date of birth. D is correct because standard tube labels include patient full name and date of birth at minimum, along with the medical record number, date and time of collection, and the collector's initials. Two identifiers must be patient-specific. A is wrong because bed location and shift handoff time are operational details, not patient-specific identifiers. They cannot be used as identifiers on a tube label under either CLSI or Joint Commission requirements. B is wrong because room number and admission date are not patient-specific identifiers and do not meet the standard. Patients move between rooms and admission dates are not unique enough, so neither qualifies as a labeling identifier. C is wrong because diagnosis and provider name are unrelated to the patient identifier requirement. Diagnosis is not unique to a patient, and the provider name does not identify the patient at all under the labeling rule. Patient identification before specimen collection isn't a formality, it's a foundational safety mechanism. Misidentification is one of the most harmful sentinel events the Joint Commission tracks, and it's entirely preventable at a single moment before the needle enters the skin. Two patient-specific identifiers are required for any diagnostic specimen collection. Patient-specific means the information is permanently tied to that person. Full name, date of birth, and medical record number all qualify because they cannot be reassigned or changed by a room transfer. The trap is that room number, bed number, admission date, and diagnosis all sound patient-specific, but they're operationally variable. A room number changes when a patient transfers. A diagnosis changes when results arrive. Neither is reliably tied to the patient as a unique individual. The PCT asks the patient to state their name and date of birth unprompted, never asking, "Are you Jane Smith?" because a confused patient may confirm any name. Both identifiers are compared against the requisition and the tube label written at the bedside, before gloves go on and before the tourniquet is placed. Both CLSI GP41 and the Joint Commission converge on the same rule. Identifiers must be permanent and person-specific. If information can change during a hospital stay or be shared with another patient's location, it fails the standard. Question 3. A PCT is collecting blood from a patient on chronic warfarin therapy. After the draw, the PCT applies pressure for the standard time. The PCT recalls the longer pressure rule for anticoagulated patients. Which pressure duration is appropriate for this anticoagulated patient post-draw? Your options are A. 2 minutes is typical here. B. 30 seconds maximum is enough. C. 5 to 10 minutes minimum. D. Pressure is not required if no oozing. Before I reveal it, which one do you think is right? The correct answer is C. 5 to 10 minutes minimum. C is correct because anticoagulated patients require 5 to 10 minutes of firm direct pressure post-draw to prevent hematoma formation. Standard pressure of 2 to 3 minutes is too short for patients on warfarin, heparin, or other anticoagulants. A is wrong because 2 minutes matches the routine duration for non-anticoagulated patients. Anticoagulated patients require longer pressure of 5 to 10 minutes because their bleeding times are extended by the medication. B is wrong because 30 seconds is far too short for any patient and especially for those on anticoagulation. Hematoma will form rapidly because the prolonged clotting time keeps blood oozing far longer than 30 seconds of pressure. D is wrong because pressure is required even when initial oozing is not visible. Bleeding can resume after the needle is withdrawn, and skipping pressure, especially in anticoagulated patients, reliably produces hematoma in many cases. When a patient is on an anticoagulant, their ability to form a stable clot is genuinely impaired, and venipuncture creates exactly the kind of wound that needs clotting. Understanding why longer pressure is required starts with how these medications interfere with the coagulation cascade. Warfarin depresses vitamin K-dependent factors 2, 7, 9, and 10, slowing the extrinsic and common pathways. Heparin potentiates antithrombin to inhibit factor XA and thrombin. Direct oral anticoagulants block either factor XA or thrombin directly. Every mechanism pushes back the moment a stable fibrin plug seals the puncture site. Each drug class hits a different node in the cascade, but the downstream effect is the same. The fibrin plug that would normally seal a venipuncture wound in 2 to 3 minutes takes significantly longer to form. The correct technique is firm, uninterrupted pressure for a minimum of 5 to 10 minutes. Releasing early to check the site is a common error. Each release lets arterial pulsation displace the partially formed clot, restarting the process. The standard pressure window for a healthy patient is 2 to 3 minutes. For any patient on warfarin, heparin, or a direct oral anticoagulant, that window extends to 5 to 10 minutes minimum, a distinction that reflects the pharmacological reality of impaired hemostasis, not just extra caution. Question 4. A PCT collecting a routine specimen sees the patient become pale and diaphoretic and report feeling nauseated and lightheaded. The patient is still seated in the phlebotomy chair. Which action is the priority response from the PCT in this scenario? Your options are A. Continue the draw to finish quickly. B. Apply a tourniquet for pressure. C. Encourage the patient to walk it off. D. Remove the needle and recline the patient. What's your answer? Commit to one before I continue. The correct answer is D. Remove the needle and recline the patient. D is correct because these are vasovagal prodromal symptoms. The PCT removes the needle, activates the safety device, applies pressure, and reclines the patient to prevent loss of consciousness. Cool cloth and reassurance follow as recovery measures. A is wrong because continuing the draw risks a syncopal episode mid-procedure with the needle still in place. The standard response is to stop, remove the needle safely, and protect the patient from a fall. B is wrong because a tourniquet is unrelated to vasovagal management. Applying one does not address the underlying drop in cerebral perfusion that is causing the symptoms in this scenario at the chair side. C is wrong because encouraging an upright walk worsens vasovagal symptoms by reducing cerebral perfusion further. The correct response is to recline the patient so blood returns to the brain rather than to upright the patient unsafely. Vasovagal syncope is the most common and most preventable adverse event in blood collection. Understanding why it happens and how to recognize it early is what separates a safe draw from a dangerous one. The prodromal phase gives you a window to act. Pallor, diaphoresis, nausea, lightheadedness, yawning, or a sudden sense of warmth are not minor complaints. They are the body signaling that cerebral perfusion is about to drop. Every one of these signs is an instruction to stop. The vagus nerve is the trigger in response to pain, anxiety, or the sight of blood. It fires and causes a sudden drop in both heart rate and blood pressure. With less pressure driving blood upward, cerebral perfusion falls and the patient loses consciousness. The response is immediate and specific. Remove the needle with the safety device engaged, apply firm pressure to the site, then recline the patient. Lowering the head below heart level uses gravity to restore cerebral perfusion. That is the physiological goal. A cool damp cloth supports recovery, and the patient must not sit or stand until fully oriented. 3 events share similar signs but differ in trigger and timing. Vasovagal syncope happens during the seated draw, caused by the needle or anxiety. Hypoglycemia presents similarly but requires glucose management. Orthostatic hypertension occurs when the patient stands, not while sitting. Trigger and timing are the distinguishing features. Question 5. A PCT is assigned to a severely immunocompromised allogeneic stem cell transplant patient. The room uses positive pressure ventilation with HEPA filtration, no fresh flowers, and limits on visitors with respiratory symptoms. What is the goal of this protective environment? Your options are A. Protect the patient from environmental pathogens. B. Protect staff from the patient's organisms. C. Save energy and laundry resources. D. Prevent allergic reactions to flowers. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Protect the patient from environmental pathogens. A is correct because a protective environment uses positive pressure to keep environmental pathogens out of the room. The goal is to protect a severely immunocompromised patient from organisms in the corridor air or on visitors, the opposite of airborne isolation. B is wrong because protecting staff from patient organisms describes airborne isolation with negative pressure. The protective environment direction is reversed, with air flowing out of the room toward the corridor to keep pathogens away from the patient. C is wrong because energy or laundry savings are not the rationale. The room-specific ventilation design exists for clinical infection control reasons, and any utility benefit would be incidental rather than the primary purpose of the configuration. D is wrong because allergic reactions to flowers are a separate issue from airborne fungi and pathogens. The fresh flower restriction relates to environmental fungi like aspergillus rather than allergy, and it fits within the broader pathogen protection design. A protective environment, sometimes called reverse isolation, is designed to shield a highly vulnerable patient from the outside world, not to protect others from the patient. Understanding this reversal is the key to mastering this concept. The distinction comes down to airflow direction. In airborne isolation, negative pressure pulls corridor air inward and exhausts it safely, isolating a dangerous patient. In a protective environment, positive pressure pushes clean filtered air outward, keeping pathogens away from a vulnerable patient. HEPA filtration removes particles down to 0.3 microns, capturing fungal spores before air enters the room. At least 12 air changes per hour maintain the positive pressure gradient, and a pressure indicator at the door confirms the room is functioning correctly. Multiple transmission routes are addressed simultaneously. Fresh flowers and potted plants are banned because they harbor aspergillus spores. Visitors with respiratory symptoms are restricted, and some programs use low microbial diets restricting raw produce that carry surface bacteria and fungi. The memory anchor is simple. Negative pressure sucks contaminated air in to protect others, while positive pressure blows clean air out to protect the patient. Whenever you see allogeneic transplant or severely immunocompromised on an exam, think protective environment and positive pressure. Question 6. A PCT is caring for a patient receiving a continuous tube feeding through a nasogastric tube. The patient is resting in bed and the head of the bed has been lowered by the previous shift to 10 degrees. What is the most appropriate next action for the PCT? Your options are A. Continue care without raising the head. B. Raise head flat for 1 hour. C. Right sideline at 10 degrees. D. Raise head of bed above 30 degrees. Which would you go with? Lock it in before the reveal. The correct answer is D. Raise head of bed above 30 degrees. D is correct because continuous tube feedings require head of bed elevation of at least 30 degrees, ideally 30 to 45 degrees, to reduce reflux and aspiration. A 10-degree position is unsafe with the feeding running. A is wrong because continuing care without raising the head leaves a patient with a running, feeding at high aspiration risk. Reflux of formula into the airway during continuous feeds is a real and preventable cause of pneumonia. B is wrong because flat positioning is the opposite of what is needed during feeding. Flat means the patient receives gastric contents into the airway easily, and pausing the feed for an hour does not protect the patient. C is wrong because right side at 10 degrees does not address the elevation requirement. Side-lying positioning may help drainage in other contexts, but during continuous feeds, the upright posture protects the airway better than side-lying does. When a patient receives continuous enteral feeding, keeping the head of the bed elevated is one of the most important safety measures a PCT can take. The underlying reason comes down to gravity and the anatomy of reflux. In a flat or near flat position, formula and gastric contents can reflux back up the esophagus and spill into the trachea. A sedated or neurologically impaired patient may not cough or gag, allowing formula to enter the lungs and cause chemical pneumonitis and bacterial pneumonia. The evidence-based minimum is 30 degrees, but 30 is the floor, not the target. 45 degrees is preferred because gravity more effectively opposes retrograde gastric flow at that angle. The entire head section of the bed must be raised using the bed's articulation control, not just pillows. As a PCT, if you find a tube feeding patient flat, restoring head of bed elevation is within your scope and should happen before other care. Do not confuse side-lying, used for oral care, with adequate protection during active feeding, and never mistake Trendelenburg positioning for aspiration prevention. Whenever continuous enteral feeding is running, head of bed elevation is non-negotiable. Gravity working along the length of the esophagus is what keeps gastric contents from reaching the airway. Question 7. A PCT is helping with a 24-hour urine collection. The patient asks how to handle the very first morning void on the day collection begins. Which instruction matches the standard for a 24-hour urine collection start time and first void handling for the patient? Your options are A. Collect first void in container. B. Collect first void in separate container. C. Discard first void and start the clock. D. Refrigerate the first void only. Don't overthink it. Which one feels right? The correct answer is C. Discard first void and start the clock. C is correct because for 24-hour urine collections, the patient discards the first morning void and notes the time. All subsequent voids are collected in the container, including the next morning's first void at the same time. A is wrong because collecting the first void in the container starts the clock with urine that has accumulated overnight in the bladder. The standard discards this initial sample and begins timing from the discard, not the collection. B is wrong because splitting the first void into a separate container is not the standard for 24-hour collection. The first void is discarded entirely. Only subsequent voids and the final void at the 24-hour mark are collected. D is wrong because refrigerating the first void to use later mixes timing rules and creates confusion. The first void is discarded, not stored for later inclusion, because the bladder content represents urine produced before the time collection started. A 24-hour urine collection measures total renal excretion of a substance over a full diurnal cycle, because the kidneys don't excrete at a constant rate throughout the day. A single void can't approximate what a complete time collection captures. The collection begins not when you first collect into the jug, but at the moment you discard the first morning void. That void contains urine produced during sleep, urine from outside your 24-hour window, so it must be discarded and the clock time noted. From that discard time forward, every void goes into the collection container. The collection closes at the same clock time the following morning, and that final void must be included. It clears urine produced during the last interval of the window. Including the first void extends the effective collection beyond 24 hours and systematically overestimates the analyte. Patient instructions must be explicit. Discard the first morning void, record that time, and collect every void after that, including the next morning's first void to close the window. On the exam, any question about what to do with the first morning void in a timed collection is testing the single principle. Discard it, record the time, and let that moment start the clock. Question 8. A PCT is caring for a hospice patient with terminal restlessness in the final hours of life. The patient is modeled at the extremities and has cyclic, deep, then shallow breathing with apneic pauses. The family asks what they can do to comfort the patient near the end. Your options are: A. Turn lights up to keep alert. B. Encourage the patient to eat and drink. C. Reposition the patient every hour briskly. D. Speak quietly and gently to the patient. Got a guess? Lock it in. The correct answer is D. Speak quietly and gently to the patient. D is correct because hearing is the last sense to fade. Speaking gently to the patient and offering quiet presence is one of the most meaningful comfort actions families can take during the final hours of life. A is wrong because turning lights up runs counter to the calm, dim environment most dying patients tolerate best. Bright stimulation does not improve outcomes and may add to terminal restlessness rather than soothing the family or the patient. B is wrong because encouraging eating and drinking near death is harmful because the swallowing reflex is gone and aspiration becomes likely. Comfort care focuses on mouth moisture and lip care rather than nutrition delivery during the active dying phase. C is wrong because brisk repositioning every hour can be uncomfortable and overstimulating in the final hours of life. Gentle, less frequent repositioning for comfort is appropriate at this stage rather than routine schedules used earlier in care. When a patient enters the final hours of life, the clinical goal shifts completely, from treatment and recovery to comfort and dignity. Understanding what is still happening inside the dying body shapes everything about how care is given. 4 predictable changes mark active dying. Circulation withdraws from the extremities, causing mottling and skin coolness. Breathing becomes irregular, the pattern known as Cheney-Stokes, with pauses called apnea. The jaw relaxes, producing secretion sounds, and consciousness fades, making the patient appear unresponsive. Neurological evidence consistently shows that hearing is the last sense to fade. Even when a patient cannot respond, auditory processing continues. This means speaking gently to a dying patient is not symbolics. It is clinically supported comfort care. Much remains meaningful even when the patient cannot respond. Speak softly and directly to them. Hold their hand. Keep lips moist with a glycerin swab. Dim the lights and reduce noise to lower the risk of terminal restlessness, a state of agitation that is difficult to manage in the final hours. Equally important is what to avoid. Encouraging oral intake when swallowing has diminished risks, aspiration. Bright lights and loud noise worsen terminal restlessness. Aggressive repositioning on a 2-hour schedule causes pain without benefit at this stage. Routine recovery protocols do not belong in final hours care. Question 9. A PCT is monitoring a patient who develops an irregular rhythm with multiple distinct P-wave morphologies. There appear to be at least 3 different P shapes in lead 2. The rate is 110. Which arrhythmia best fits this finding on the strip? Your options are: A. Atrial fibrillation with chaotic baseline. B. Atrial flutter with sawtooth waves. C. Multifocal atrial tachycardia. D. Sinus arrhythmia with respiratory variation. Which one is it? Pause the video if you need more time. The correct answer is C. Multifocal atrial tachycardia. C is correct because multifocal atrial tachycardia shows 3 or more distinct P-wave morphologies in the same lead with an irregular rhythm at over 100 per minute. It is associated with severe COPD or critical illness requiring underlying cause focus. A is wrong because atrial fibrillation shows a chaotic baseline without organized P waves rather than 3 distinct P morphologies. The defining feature of MAT is multiple P wave shapes, which is incompatible with the absent P waves of fibrillation. B is wrong because atrial flutter shows sawtooth flutter waves at about 300 per minute, not multiple P morphologies. The pattern in the scenario specifically describes distinct P shapes, which fits MAT rather than the regular sawtooth of flutter. D is wrong because sinus arrhythmia involves respiratory rate variation with one consistent P wave morphology. Multiple distinct P shapes are not part of sinus arrhythmia, so this label does not apply to the rhythm described in the scenario. Multifocal atrial tachycardia is a rhythm driven by competition between multiple irritable foci in the atria, each firing independently and generating its own distinct P wave. Understanding what makes it unique starts with how normal atrial automaticity works. Each competing focus fires from a different location, so the electrical wavefront travels in a unique direction with every beat. This is why each P wave has a different shape. 3 or more distinct P wave morphologies in a single lead is the defining criterion for MAT. MAT requires all 3 features, at least 3 distinct P wave morphologies, an irregularly irregular rhythm because each focus fires at its own unpredictable time, and a rate above 100 beats per minute. The same phenomenon below 100 is called wandering atrial pacemaker. The critical exam trap is separating MAT from atrial fibrillation, since both are irregularly irregular. In atrial fibrillation, there are no organized P waves at all, only a chaotically undulating baseline. In MAT, clear P waves are visible before every QRS, but they come in 3 or more different shapes. MAT is strongly associated with COPD, hypoxia, hypomagnesemia, and theophylline toxicity. The clinical approach targets the underlying cause, improving oxygenation, correcting hypomagnesemia, or removing theophylline. Unlike atrial fibrillation, MAT does not respond reliably to rate control medications unless the root cause is addressed first. Question 10. A PCT is reviewing the role of the SA node and AV node together. The instructor describes a situation where the SA node fails completely. Which structure typically takes over as the next pacemaker? And what intrinsic rate does that structure produce as backup? Your options are A. AV junction 40 to 60, B. Bundle branches at 30 per minute, C. Purkinje fibers at 100 per minute, D. Right atrium at 90 per minute. Take a second. Which answer would you pick? The correct answer is A. AV junction 40 to 60. A is correct because when the SA node fails, the AV junction takes over as the backup pacemaker at 40 to 60 beats per minute. If both fail, the ventricular Purkinje system escapes at 20 to 40 beats per minute. B is wrong because bundle branches do not have a typical pacemaker rate of 30 per minute. The hierarchy is SA, then AV junction, then ventricular Purkinje at 20 to 40, with bundle branches being conduction structures rather than primary pacemakers. C is wrong because Purkinje fibers fire at 20 to 40 per minute, not 100. They are the slowest backup, not the next in line backup, which is the AV junction at 40 to 60 beats per minute on the standard hierarchy. D is wrong because the right atrium itself does not fire automatically except through the SA node. Ectopic atrial pacemakers do not have a defined 90 per minute rate, and the standard backup is the AV junction at 40 to 60. The heart has a built-in backup system, a hierarchy of pacemaker cells, each ready to take over if the one above it fails. This redundancy is a life-saving feature of cardiac physiology called overdrive suppression, where the fastest pacemaker silences the slower ones below it. There are 3 levels in the hierarchy. The SA node fires at 60 to 100 beats per minute and normally dominates. The AV junction serves as the first backup at 40 to 60. The ventricular Purkinje system is the last resort at 20 to 40, dangerously slow and often inadequate to maintain organ perfusion. The QRS width tells you where the escape rhythm originates. A junctional escape uses the normal His-Purkinje pathway, producing a narrow QRS. An idioventricular rhythm spreads slowly through ventricular muscle cell to cell, producing a wide, bizarre QRS. Rate and QRS width together identify the level. The most testable confusable is junctional escape versus idioventricular rhythm. Junctional 40 to 60 narrow QRS. Idioventricular 20 to 40 wide QRS. Students frequently swap these two rates. Remember, the AV junction is the first backup, so its rate is always higher than the ventricular rate. Lock in these three rate ranges and pair each with its QRS width. When you see SA node failure on an exam, the AV junction takes over first at 40 to 60 with a narrow QRS, not the ventricles. Question 11. A PCT measures pitting edema on a patient's lower legs by pressing the thumb firmly over the tibia for 5 seconds. The thumb sinks about 6 millimeters and the indentation rebounds in roughly 30 seconds. Which grading is most consistent with these observations? Your options are A. Grade 1 plus pitting edema, B. Grade 3 plus pitting edema, C. Grade 4 plus pitting edema, D. Grade 2 plus pitting edema. Before I reveal it, which one do you think is right? The correct answer is B. Grade 3 plus pitting edema. B is correct because grade 3 plus pitting edema is roughly 6 millimeters of depth with rebound near 30 seconds. Grade 1 is 2 millimeters with immediate rebound. Grade 4 is 8 millimeters or deeper with rebound over 1 minute. A is wrong because grade 1 plus represents about 2 millimeters of indentation with immediate rebound. The depth and rebound time in this scenario are far greater than grade 1, so this rating significantly understates the patient's swelling. C is wrong because grade 4 plus represents an 8 millimeter or deeper indent with rebound over 1 minute. The findings here, 6 millimeters and 30 seconds, fall short of those thresholds and would overrate the patient's edema if assigned. D is wrong because grade 2 plus is about 4 millimeters with rebound under 15 seconds. The depth and rebound time exceed those values, so grade 2 does not match the recorded measurement and would underestimate the swelling. Pitting edema grading gives clinicians a shared, objective language for tracking fluid accumulation in peripheral tissues. Rather than vague descriptors like mild or moderate, the 4+ scale ties specific indentation depths to specific rebound times, allowing meaningful comparison across shifts and providers. When you press into edematous tissue, fluid is displaced from the subcutaneous space. The indentation persists until interstitial fluid seeps back in. The rate of return reflects the fluid's protein content. Low protein transudative fluid rebounds more slowly and produces deeper pitting. Each grade pairs a depth measurement with a rebound time. Grade 1 plus is 2 millimeters rebounding in under 15 seconds. Grade 2 plus is 4 millimeters in 15 to 30 seconds. Grade 3 plus is 6 millimeters in 30 to 60 seconds. Grade 4 plus is 8 or more millimeters taking over a full minute to rebound. The most common trap is confusing grade 3 and grade 4, since their rebound times border on 30 seconds. A 30-second rebound belongs to grade 3 plus. Only a rebound lasting beyond 1 full minute reaches grade 4 plus. Miscalling this boundary can directly influence escalation decisions in conditions like congestive heart failure. Always press firmly over the shin or dorsum of the foot for 5 full seconds before measuring depth and timing rebound. Pairing the exact millimeter depth with the exact rebound window is what determines the correct grade and ensures accurate trending over time. Question 12. A PCT is bathing an elderly patient and notices several bruises in different stages of healing on the torso, along with what looks like a belt buckle pattern on the back. The patient becomes anxious when the family caregiver enters the room. What should the PCT do first? Your options are A. Confront the caregiver privately. B. Document findings and ask the caregiver. C. Promise the patient confidentiality. D. Document objectively and report to the nurse. What's your answer? Commit to one before I continue. The correct answer is D. Document objectively and report to the nurse. D is correct because bruising in different stages, patterned injuries, and behavioral fear cues meet the threshold for suspected abuse. The PCT documents what is seen objectively and reports promptly so social services can begin the investigation. A is wrong because confronting the suspected abuser is unsafe and outside PCT scope. Confrontation can cause the caregiver to retaliate against the patient or remove them from the facility before social services, and the nurse can intervene safely. B is wrong because asking the caregiver gives the suspected abuser an opportunity to coach the patient or shape an explanation. Mandated reporters report to the supervising team and protective services, not to the person who may be causing the harm. C is wrong because promising confidentiality is impossible because PCTs are mandated reporters. Telling the patient otherwise and then reporting anyway destroys trust, while the legal duty to report suspected abuse cannot be waived by an informal promise. Mandatory reporting is a legal and ethical obligation for every healthcare worker, including PCTs, regardless of role or credential level. You don't need certainty to report. Reasonable suspicion based on observable evidence is enough to trigger the obligation. 3 categories of observable evidence should trigger your suspicion: pattern injuries or burns that don't match the reported cause, bruising in multiple color stages suggesting repeated harm over time, and behavioral cues, like a patient going silent when a specific caregiver enters the room. PCTs often have longer, uninterrupted visual access to a patient's body than any clinician. 20 minutes of bathing reveals what a 3-minute nursing assessment may never see: patterned bruising, burn marks, or wounds inconsistent with the patient's mobility level. The correct response is a 2-part sequence: objective documentation followed by prompt reporting to the nurse and care team. The PCT records size, color, location, and pattern in precise anatomical terms. No interpretation. The nurse and social services draw conclusions. The PCT's role is accurate observation and timely reporting. 4 actions that seem helpful but are always wrong. Confronting the abuser escalates danger and may cause the patient to be removed before protective services intervene. Promising confidentiality is impossible under mandated reporter law. Asking the caregiver to explain alerts them before the investigation begins. And delaying reporting to gather more evidence puts the patient at continued risk. Question 13. A PCT is helping a patient with right hemiplegia change into a hospital gown. The patient has limited use of the right arm and the left arm is normal strength. To dress the patient correctly to protect the affected limb, which arm should go through the gown sleeve first? Your options are A. The right affected arm first. B. Either arm depending on patient choice. C. Both arms simultaneously. D. The left strong arm first. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. The right affected arm first. A is correct because the affected limb is dressed first because the unaffected arm has the flexibility to complete the sleeve. When undressing, the unaffected arm comes out first, also to protect the weak side from strain. B is wrong because patient choice is respected for many tasks. But for dressing a hemiplegic patient, technique determines safety. Letting the patient choose against the rule can cause unnecessary shoulder strain on the affected side. C is wrong because dressing both arms simultaneously is impossible with most gowns and would still place strain on the affected limb. The affected first method exists specifically because sequential limb-by-limb dressing is the only practical approach. D is wrong because putting the strong arm through first locks the affected arm into an awkward range of motion when the second sleeve must go on her. This twists the weak shoulder and increases the risk of joint strain and pain. When a patient has unilateral weakness or paralysis, dressing and undressing follow a specific sequence designed to protect the affected joint and prevent injury. The rule is straightforward. Dress the weak side first, undress the weak side last. This keeps the unaffected arm free to guide the garment, while the caregiver positions the affected limb gently through the sleeve. The affected limb in hemiplegia has reduced range of motion, altered muscle tone, and impaired proprioception. Dressing that arm last, when the torso is already half dressed, forces a torsional stress on the shoulder the patient cannot compensate for. Watch out for the classic exam trap. An IV line in one arm reverses the sequence. The IV arm goes in last, so tubing can be managed. Hemiplegia and IV arm care produce opposite sequencing, so identify the clinical situation before applying either rule. Patients often prefer to lead with their stronger arm, but the PCT explains the reason and follows the correct technique. Joint safety takes priority, and the sequence applies consistently across all upper body garment types. Question 14. A PCT is asked about transport temperature for blood cultures after collection. The lab supervisor mentions that incorrect transport temperature is a common pre-analytical error. Which temperature condition is appropriate for transport of blood culture bottles to the laboratory? Your options are A. Refrigerated at 4 degrees Celsius. B. Frozen on dry ice immediately. C. Room or body temperature, never refrigerated. D. Heated to 42 degrees Celsius. Which would you go with? Lock it in before the reveal. The correct answer is C. Room or body temperature, never refrigerated. C is correct because blood culture bottles must be transported at room or body temperature and reach the incubator within 30 to 60 minutes. Refrigeration kills temperature-sensitive organisms, producing falsely negative cultures and misdiagnosis of bacteremia. A is wrong because refrigeration kills temperature-sensitive organisms in blood culture bottles. This is one of the classic and most damaging errors in specimen transport for blood cultures, and it results in false negative results. B is wrong because freezing on dry ice destroys the very organisms the lab is trying to grow. Blood cultures need warm conditions for growth, not cold storage, which is reserved for some specific reference lab analytes. D is wrong because heating bottles above body temperature can damage some organisms and is not the standard. Room or body temperature is the correct range, with the incubator reaching 35 to 37 degrees once received. Blood culture transport is unlike almost every other phlebotomy procedure because the goal is keeping living organisms alive long enough to grow in the incubator. Any temperature error that kills those organisms before they arrive produces a false negative result, and a patient with undetected bacteremia may progress to sepsis without targeted treatment. 4 temperature zones matter here. Refrigerator temperature at 4 degrees Celsius kills sensitive organisms in transit. 42 degrees is too hot and damages thermolabile species. Dry ice freezing destroys everything entirely. Only room temperature, close to body temperature, keeps organisms viable for the incubator. After collection, bottles should travel at room temperature and reach the laboratory incubator, set at 35 to 37 degrees Celsius. What team? Within 30 to 60 minutes. If the pneumatic tube system has not been validated for blood cultures, bottles must be hand-delivered to avoid mechanical agitation of the broth. Refrigeration is flagged in phlebotomy training as the single most damaging blood culture pre-analytical error, and one of the most common made by staff unfamiliar with blood culture specific rules. The culture grows negative not because the patient is bacteremia free, but because organisms were killed in transit. The clinical consequence is missed sepsis. The exam tests whether you can distinguish blood culture rules from other analyte rules. Ammonia needs ice. Cold agglutinins need warmth, but blood cultures need room temperature and prompt incubation. When you see blood culture bottles in a question, think room temperature, hand deliver if needed, incubator within the hour. Question 15. A PCT places a confused but ambulatory patient at high fall risk into bed at the lowest position with 2 upper side rails up. Family later raises all 4 side rails because the patient keeps trying to climb out, which best describes the 4-rail configuration the family created. Your options are A. A standard fall precaution, B. A restraint requiring a physician order, C. A comfort positioning support, D. An equipment maintenance safeguard. Don't overthink it. Which one feels right? The correct answer is B. A restraint requiring a physician order. B is correct because raising all 4 rails to prevent a patient from exiting bed meets the federal definition of a restraint and requires a physician order with regular monitoring. 2 upper rails alone are generally not considered a restraint. A is wrong because raising all 4 rails goes beyond standard fall precautions because the patient can no longer leave the bed independently. The configuration creates a confined space that meets the restraint definition rather than ordinary fall prevention. C is wrong because comfort positioning typically uses pillows or partial rails for repositioning support. 4 full rails up to prevent voluntary exit shifts, the purpose from comfort to confinement, which is the regulatory test for a restraint. D is wrong because equipment maintenance safeguards refer to inspection and repair of beds, not to rail configurations during patient care. Family raising all 4 rails to prevent exit is unrelated to maintenance and meets the restraint criteria instead. Side rail configuration is not just a safety preference, it sits squarely inside federal restraint law. Understanding the dividing line between a fall prevention aid and a regulated restraint tells you exactly what actions are required and by whom. The Centers for Medicare and Medicaid Services define a restraint as any method, physical or mechanical, that restricts freedom of movement or normal access to one's own body. The single key test is whether the configuration prevents the patient from voluntarily leaving the bed. Intent and reason are irrelevant to that test. Raising only the 2 upper rails leaves the foot of the bed open so the patient can still exit voluntarily. That configuration is a positioning and comfort aid, no order required. Raising all 4 rails eliminates every exit route, converting the bed into a confined space. That meets the restraint definition and requires a physician order with documented justification and regular monitoring. Visually, the distinction comes down to the foot of the bed. The 2 upper rails leave that exit path open. The moment the foot rails are also raised, no voluntary exit route remains and the regulatory clock starts. When a family member raises all 4 rails, their protective intent does not grant them authority to apply a de facto restraint. The PCT must lower the unauthorized foot raise and immediately notify the nurse. The care team then assesses whether a formal restraint order is clinically indicated and whether alternatives, bed alarms, hourly rounding, non-skid footwear, or a sitter, can address the family's concern instead. Question 16. A PCT is preparing to enter the room of a patient with active pulmonary tuberculosis. The patient is in a negative pressure airborne infection isolation room. Which respirator must the PCT wear during care, and what fitting requirement is essential before use? Your options are A. Surgical mask, no fitting required. B. Cloth mask, casual fit acceptable. C. P100 respirator, no testing needed. D. N95 respirator, fit tested with seal check. Got a guess? Lock it in. The correct answer is D. N95 respirator, fit tested with seal check. D is correct because airborne precautions for tuberculosis require an N95 respirator or higher. Workers must be fit tested annually and complete a user seal check at every entry to verify the respirator forms a tight protective seal. Was wrong because surgical masks do not filter airborne droplet nuclei small enough to carry tuberculosis. They are designed for droplet protection, not airborne, and they offer minimal protection against this size of infectious particle entirely. B is wrong because cloth masks lack filter efficiency and seal. They do not meet the standard for airborne protection and are unsuitable for any precaution category in a healthcare setting where respiratory pathogens are confirmed or suspected. C is wrong because P100 filters are powerful but rare in routine inpatient TB care, and they still require fit testing. The standard answer for typical TB room entry is the fit-tested N95, with a seal check on entry. Tuberculosis requires the most rigorous respiratory precautions because Mycobacterium tuberculosis spreads through droplet nuclei, particles under 5 microns that stay suspended in room air and travel far beyond the 3-foot radius of ordinary droplet precautions. Particle size is what determines the precaution level. Larger droplet particles settle fast and a surgical mask is adequate, but tuberculosis droplet nuclei require an N95 respirator. A surgical mask is explicitly insufficient because it cannot seal against particles this small. The N95 designation means at least 95% filtration at the smallest particle size when fitted correctly. OSHA mandates annual fit testing to confirm the specific model seals on that worker's face. Even a fit-tested mask must pass a seal check. Positive and negative pressure every single time it is put on. The isolation room itself is a critical control. It is maintained at negative pressure so air flows inward from the corridor and exhausts outside, preventing droplet nuclei from escaping when the door opens. The minimum standard is 12 air exchanges per hour, and the door must stay closed to preserve that pressure differential. Remember, tuberculosis is airborne, not droplet. Influenza and pertussis use a surgical mask. TB demands an N95 that has been fit tested and seal checked in a negative pressure room. Any exam question linking tuberculosis to a surgical mask is describing a specific testable error. Question 17. A PCT is asked about the role of two-identifier patient ID at the bedside before specimen collection. The supervisor mentions a rare but catastrophic outcome of misidentification involving blood bank specimens. Which adverse event is most associated with mislabeled blood bank tubes during typing and cross-match? Your options are A. Fatal hemolytic transfusion reaction, B. Brief patient embarrassment, C. Mild nausea after the draw, D. Minor delay in test results. Which one is it? Pause the video if you need more time. The correct answer is A. Fatal hemolytic transfusion reaction. A is correct because mislabeled blood bank specimens can lead to a wrong type transfusion and a fatal hemolytic transfusion reaction. This is why pink or lavender blood bank tubes require strict bedside identification with two identifiers and accurate labeling. B is wrong because brief patient embarrassment understates the severity of mislabeling consequences. The actual concern is fatal hemolytic transfusion reaction, a life-threatening event that drives the strict labeling rules for blood bank specimens. C is wrong because mild nausea after the draw is unrelated to misidentification. The catastrophic outcome of mislabeling blood bank specimens is the wrong type transfusion, not an adverse reaction at the time of the draw itself. D is wrong because minor delay in results does not capture the danger. Mislabeling can route the wrong specimen to typing, leading to wrong type transfusion later, which is a serious patient safety event rather than a minor inconvenience. When a blood bank specimen is mislabeled, the error doesn't cause harm at the draw. It travels invisibly through the laboratory system and strikes the patient at the bedside during transfusion. A patient with blood type A carries pre-existing anti-B antibodies. When incompatible type B red cells enter the bloodstream, those antibodies bind immediately, activating complement and causing rapid destruction of the transfused cells right inside the blood vessels. The destruction of transfused cells releases free hemoglobin, triggers clotting pathways, and can cause renal failure and cardiovascular collapse, all within minutes of starting the transfusion. If the specimen belongs to the wrong patient, every downstream test is corrupted. The type is wrong. The cross-match uses the wrong serum, and an incompatible unit is cleared for transfusion, each step amplifying the original labeling error. This is why blood bank labeling requirements, bedside labeling, armband verification, secondary barcodes exceed routine standards. No single safeguard is considered enough protection against a consequence this immediate and this severe. Question 18. A PCT is helping an unvaccinated co-worker after an exposure to a patient with a positive hepatitis B surface antigen status. The co-worker has just washed the wound. According to OSHA-aligned post-exposure protocols, what is the next critical step for the unvaccinated co-worker? Your options are A. Take a single antibiotic course. B. Wait 3 months for serology. C. Begin hepatitis B, immune globulin and vaccine. D. Avoid follow-up to reduce stress. Take a second. Which answer would you pick? The correct answer is C. Begin hepatitis B, immune globulin and vaccine. C is correct because an unvaccinated worker exposed to HBsAg positive source receives hepatitis B, immune globulin, and starts the hepatitis B vaccine series promptly. Post-exposure prophylaxis is most effective when started within 24 hours of exposure. A is wrong because antibiotics do not treat hepatitis B exposure because the exposure is viral. Antibiotics are not part of the protocol, and the correct step uses immune globulin and vaccine specifically directed at the hepatitis B virus. B is wrong because waiting 3 months for serology delays the time-critical post-exposure prophylaxis. HBRG and vaccine are most effective when started early, so deferring intervention removes the protection window that the protocol relies on. D is wrong because avoiding follow-up after a confirmed exposure leaves the worker without the standard protective regimen and ongoing testing. Post-exposure protocols exist precisely so workers receive appropriate care after a real and time-sensitive exposure event. When an unvaccinated worker is exposed to a hepatitis B positive source, the response must be immediate. Hepatitis B is the highest risk blood-borne pathogen for needle-stick transmission, with infection probability reaching up to 30%. Etc. far exceeding HIV's risk from the same exposure. Hepatitis B carries a needle-stick transmission risk of 6 to 30% in unvaccinated individuals. By comparison, HIV transmission from a single needle stick is roughly 0.3%. Hepatitis C falls in between. But unlike hepatitis B, it has no approved post-exposure prophylaxis, only monitoring and early antiviral treatment if seroconversion occurs. The protocol combines passive and active immunity given simultaneously. HBRG delivers preformed antibodies to neutralize viral particles before they establish cellular infection. The hepatitis B vaccine series triggers the worker's own immune response for durable long-term protection. Together they are substantially more effective than either component alone. HBRG works immediately by neutralizing circulating virus, while the vaccine trains the immune system over weeks and months. Both are administered at separate injection sites during the same visit. ideally within 24 hours of exposure. HBIG provides meaningful protection only when given within 24 hours. After 7 days from a percutaneous exposure, it offers no clinically significant benefit. The window for neutralizing circulating virus has closed. This is why immediate reporting after washing the wound is the critical first action, not waiting for a convenient appointment. Question 19. A PCT is documenting EKG paper settings before a tracing. The standard paper speed is selected on the machine. At the standard speed, how much time does one small box on the EKG paper represent horizontally for routine 12-lead recording in adults? Your options are A. 0.02 seconds, B. 0.10 seconds, C. 0.20 seconds large box, D. 0.04 seconds. Before I reveal it, which one do you think is right? The correct answer is D, 0.04 seconds. D is correct because at the standard paper speed of 25 millimeters per second, one small box represents 0.04 seconds horizontally. 5 small boxes equal one large box, which represents 0.20 seconds. A is wrong because 0.02 seconds represents one small box at 50 millimeters per second, the fast speed used for some pediatric or fast rhythm recordings. It is not the value at the standard 25 millimeter per second paper speed. B is wrong because 0.10 seconds is one large box at 50 millimeters per second. At the standard speed, a large box represents 0.20 seconds, and a small box represents 0.04 seconds. C is wrong because 0.20 seconds is the value of one large box, not one small box. The two scales are commonly confused, and the small box represents 0.04 seconds at the standard paper speed. EKG paper calibration is what transforms grid boxes into clinically meaningful measurements. At the standard recording speed of 25 millimeters per second, every box on the paper has a precise time value. The small box measures 1 millimeter and represents 0.04 seconds, derived by dividing 1 millimeter by 25. The large box spans 5 millimeters and equals 0.20 seconds. 5 consecutive large boxes equal exactly 1 second of recording time. It is critical to keep the two axes separate. Horizontally, the boxes measure time. Vertically, one small box equals 0.1 millivolt and one large box equals 0.5 millivolt. Mixing these two scales is one of the most common exam errors. These calibration values underpin every standard interval measurement. A normal PR interval of 0.12 to 0.20 seconds equals 3 to 5 small boxes. A normal QRS duration under 0.12 seconds equals fewer than 3 small boxes. At 50 millimeters per second, double the standard speed. Each small box represents only 0.02 seconds. Tracings appear stretched horizontally. Applying the standard 0.04 value doubles every calculated interval, potentially causing false diagnoses of conduction abnormalities. Question 20. A PCT is providing oral care to an unconscious patient with no airway device in place. The patient has thick secretions pooling in the mouth. Before beginning oral care, what is the most important position for the patient to reduce aspiration risk? Your options are A. Supine with the head of bed flat, B. Side lying with head turned to the side, C. Trendelenburg with mouth pointing down, D. High Fowlers with chin tucked to chest. What's your answer? Commit to one before I continue. The correct answer is B. Side lying with head turned to the side. B is correct because side lying with the head turned lets fluid drain out of the mouth onto a towel rather than down the airway. This is the single most tested point on oral care for unconscious patients. A is wrong because supine with head of bed flat directs gravity towards the airway. Any fluid introduced during oral care drains backward into the trachea, causing aspiration pneumonia in a patient who cannot protect their own airway. C is wrong because Trendelenburg places the head lower than the feet and is rarely used at all in modern practice. It does not solve aspiration risk because secretions still pool against the airway opening rather than draining laterally. D is wrong because half fowlers with chin tucked is good for conscious eating, but an unconscious patient cannot maintain that position safely and may slump forward, blocking the airway with the chin against the chest. When a patient is unconscious, routine oral hygiene becomes a patient safety procedure. The gag reflex and swallowing reflex are absent or severely diminished, meaning fluid introduced into the mouth can track directly into the trachea and cause aspiration pneumonia. In the supine flat position, gravity directs fluid straight toward the airway opening. Without an intact swallowing reflex to close the larynx, even small amounts of rinse fluid or secretions can enter the trachea before the caregiver can react. The correct position is side-lying with the head turned toward the dependent side. Gravity now directs fluid and secretions out of the oral cavity, onto a towel or into a suction device, rather than toward the trachea. Positioning is the primary defense against aspiration during oral care. Equipment preparation is equally critical. The suction catheter must be connected before you begin. Foam swab should be wrung nearly dry, and any pooling fluid must be suctioned before turning the patient. Evidence-based ICU protocols recommend oral care every 2 to 4 hours to reduce hospital-acquired pneumonia. The exam key is recognizing consciousness. Unconscious patients need side-lying positioning and suction to compensate for absent protective reflexes. High fowlers and upright positions are correct for conscious patients, but dangerously wrong here, because gravity and missing reflexes work against the unprotected airway. Question 21. A PCT is preparing to record a 12-lead EKG on a patient who cannot lie flat due to severe dyspnea. The patient is in semi-fowlers at 30 degrees. To support proper documentation of this non-standard position, what should the PCT do during the recording today? Your options are A. Document the angle on the EKG header. B. Force the patient flat for accuracy. C. Cancel EKG until lying flat possible. D. Skip patient identifiers if seated. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Document the angle on the EKG header. A is correct because when the patient cannot lie flat, the EKG is recorded in semi-fowlers and the angle is documented on the tracing. The interpreter accounts for positional differences, and a recorded EKG is better than none for time-sensitive workups. B is wrong because forcing a dyspneic patient flat worsens breathing and is unsafe. The standard accommodates upright patients with documentation of the position, so the interpreter can account for any positional changes in waveform interpretation. C is wrong because cancelling the EKG denies the team timely diagnostic information. The acute chest pain or ischemia workup needs the EKG promptly, and accommodation with documentation is the standard rather than cancellation. D is wrong because skipping patient identifiers violates the labeling rule even in non-standard positions. Identifiers must accompany every recording regardless of patient position, and skipping them creates a critical safety and identification error. When a patient cannot tolerate lying flat, the EKG still needs to happen. Dyspnea, heart failure, and orthopnea are common reasons patients require a semi-upright position, and none of them justify delaying this time-sensitive diagnostic tool. As the patient moves from supine to semi-fowlers, the heart shifts within the chest. The electrical axis changes slightly. The diaphragm descends with gravity, and the inferior leads in particular can look different. These are expected positional effects, not pathology. The documentation solution is simple. Before transmitting the tracing, enter the degree of head of bed elevation in the EKG machine's comment or free text field. This gives the interpreting physician the positional context needed to distinguish normal positional variation from true pathology. Position accommodation, angle documentation, and complete patient identification are all required together. They are not alternatives to each other. A tracing recorded in a non-standard position still needs every identifier on the header, so it can be matched to the correct patient record. A semi-upright EKG with proper documentation is always more useful than no EKG at all. Standard electrode positions are unchanged. Identifiers are non-negotiable, and noting the angle is what separates positional accommodation from an uninterpretable tracing. Question 20. A PCT is helping a conscious choking adult who suddenly cannot speak, cough, or breathe. The patient is alert and clutching the throat with both hands. What is the correct technique for the PCT to use immediately while standing behind the patient? Your options are A. 5 back blows between the shoulder blades. B. Chest compressions at 100 per minute. C. Abdominal thrusts above the navel. D. Wait for patient to cough alone. Which would you go with? Lock it in before the reveal. The correct answer is C. Abdominal thrusts above the navel. C is correct because conscious choke in adults receive abdominal thrusts with the fist placed just above the navel and below the xiphoid. The PCT delivers quick upward thrust until the object dislodges or the patient becomes unresponsive. A is wrong because back blows are part of the choking sequence for infants under 1 year, not adults. Adults receive abdominal thrust as the primary technique, with back blows reserved for the pediatric population using a specific paired pattern. B is wrong because chest compressions are used for unresponsive choking patients, not for conscious adults. While conscious, abdominal thrusts are the appropriate intervention because they use diaphragmatic pressure to expel the airway obstruction. D is wrong because waiting for the patient to cough fails the patient who already cannot cough or breathe. Hesitation costs oxygen during a window when a few thrusts can clear the airway and prevent loss of consciousness completely. When a conscious adult shows complete airway obstruction, the correct emergency response is abdominal thrusts, also known as the Heimlich maneuver. Understanding the underlying mechanism helps you apply it correctly and avoid the most common exam traps. The key distinction is complete versus partial obstruction. A complete obstruction, signaled by the universal choking sign and total inability to speak or cough, demands immediate abdominal thrusts. A partial obstruction, where some airflow remains, is managed by encouraging forceful coughing, because the patient's own cough generates more pressure than any external maneuver. The PCT stands behind the patient and places the thumb side of a fist just above the navel and well below the xiphoid process. The other hand covers the fist. Each quick inward and upward thrust drives the diaphragm like a piston, spiking intrathoracic pressure to expel the obstruction. Protocol depends on the patient. Conscious adults receive abdominal thrusts. Back blows are not part of AHA adult guidelines. Infants under 1 year get alternating sets of 5 back blows and 5 chest thrusts. If the adult becomes unresponsive, the PCT lowers them to the floor and transitions to a modified cardiac arrest protocol with visual airway checks between compressions. The most tested error is choosing back blows for a conscious adult that belongs to the infant protocol. Whenever you see a conscious adult who cannot speak or cough, the answer is abdominal thrust with the fist positioned just above the navel. Question 23. A PCT is asked which level of disinfection is appropriate for a flexible endoscope after a procedure. The endoscope contacted mucous membranes during the examination. Per the Spaulding classification, which reprocessing level is required for this device before next use? Your options are A. Sterilization required for each use. B. Low-level disinfection only. C. Intermediate level disinfection. D. High-level disinfection required. Don't overthink it. Which one feels right? The correct answer is D. High-level disinfection required. D is correct because endoscopes contact mucous membranes and are classified as semi-critical items per the Spaulding framework. They require high-level disinfection, typically with glutaraldehyde, orthophthalealdehyde, or peracetic acid, before being reused on the next patient on the unit. A is wrong because sterilization is required for critical items entering sterile sites. Most endoscopes cannot withstand standard sterilization processes and are reprocessed using high-level disinfection instead, which meets the semi-critical requirement under Spaulding classification rules. B is wrong because low-level disinfection is for non-critical items contacting only intact skin. An endoscope contacts mucous membranes, so this level is inadequate and would leave organisms on the device that could infect the next patient. C is wrong because intermediate level disinfection kills mycobacteria and most viruses, but does not reach the high-level standard required for semi-critical items. Endoscopes specifically require the high-level standard before next use under the framework. The Spaulding classification system is the standard framework used to determine how medical instruments must be reprocessed before being used on the next patient. Developed by Dr. Earl Spaulding in the 1960s, it remains the regulatory standard referenced by the CDC and FDA today. Every reusable device falls into one of three categories. Critical items contact sterile tissue or the vascular system. Semi-critical items contact mucous membranes or non-intact skin. Non-critical items contact only intact skin. Each category sets a minimum reprocessing standard. Critical items require full sterilization. Semi-critical items require high-level disinfection, which kills vegetative bacteria, fungi, viruses, and mycobacteria but may not eliminate all spores. Non-critical items need only low-level disinfection because intact skin prevents organism penetration. Flexible endoscopes are the classic semi-critical example. Because they contact mucous membranes but cannot withstand autoclave temperatures, high-level disinfection is both the required and the appropriate standard. Using low-level disinfection on an endoscope is an infection control violation. When an exam question describes a device touching mucous membranes, that is your signal semi-critical category. High-level disinfection required, not sterilization, not low-level disinfection. Question 24. A PCT is analyzing a rhythm strip and notes that the rhythm is irregularly irregular with no discernible P waves and a chaotic baseline. The ventricular rate is 110. Which arrhythmia best fits this description from the systematic 8-step rhythm interpretation framework? Your options are A. Atrial flutter with sawtooth waves. B. Atrial fibrillation. C. Sinus tachycardia. D. Multifocal atrial tachycardia. Got a guess? Lock it in. The correct answer is B. Atrial fibrillation. B is correct because atrial fibrillation is irregularly irregular with absent P waves, replaced by a chaotic fibrillatory baseline. Ventricular rates vary from 60 to 170. This pattern is the classic description of AFib. A is wrong because atrial flutter shows sawtooth flutter waves at about 300 per minute and is typically regular if conduction ratio is fixed. The chaotic baseline without organized waves does not match the flutter pattern described in the stem. C is wrong because sinus tachycardia is a regular rhythm with upright P waves before each QRS. The chaotic baseline and absent P waves rule out sinus origin in this strip. So the rhythm is disorganized atrial activity instead. D is wrong because multifocal atrial tachycardia has at least 3 distinct P wave morphologies. The scenario shows no discernible P waves at all, so MATI does not match the chaotic baseline described in the stem for this strip. Atrial fibrillation is the most common sustained cardiac arrhythmia, and it has a signature set of EKG findings that set it apart from every other irregular rhythm. Understanding why those findings appear requires looking at what the atria are actually doing electrically. In atrial fibrillation, hundreds of chaotic impulse wavefronts fire simultaneously across the atria at rates between 300 and 600 per minute. No coordinated depolarization occurs, so no organized P waveforms. Instead, the baseline becomes a chaotic, undulating smear. The fibrillatory baseline, which is the hallmark of this arrhythmia. The 3 defining features on the EKG are the fibrillatory baseline, the complete absence of organized P waves, and an irregular ventricular response. The AV node acts as a gatekeeper, randomly passing a fraction of atrial impulses through, so no 2 consecutive RR intervals are the same and no repeating pattern ever emerges. The most common exam traps are multifocal atrial tachycardia and atrial flutter. Multifocal atrial tachycardia has visible, discrete P waves in at least 3 different morphologies. Atrial flutter has organized sawtooth flutter waves at roughly 300 per minute. Atrial fibrillation has no organized atrial activity of any kind. When a rhythm strip shows absent P waves, a chaotic fibrillatory baseline, and a completely irregular ventricular response with no repeating pattern, that combination identifies atrial fibrillation. The ventricular rate may vary widely, but the key features are always the same. Question 25. A PCT is reviewing the chain of infection during in-service. The instructor explains that the single most effective way for the PCT to break the chain at the bedside is one specific action repeated dozens of times each shift. Which action best fits this description? Your options are A. Performing thorough hand hygiene routinely. B. Wearing gloves during every contact. C. Wearing a mask in every room. D. Using bleach on every surface. Which one is it? Pause the video if you need more time. The correct answer is A. Performing thorough hand hygiene routinely. A is correct because hand hygiene is the single most powerful intervention for breaking the chain of infection. It interrupts transmission at the most common link, the contaminated hands of healthcare workers moving between patients and surfaces. B is wrong because gloves help with specific tasks but do not replace hand hygiene. Microbes still transfer when gloves are removed if hands are not cleaned, so glove use without hand hygiene leaves the chain intact. C is wrong because masks protect against respiratory transmission for selected pathogens but do little for contact spread. Routine masking on every patient does not match the broad protective effect of consistent hand hygiene at every encounter. D is wrong because bleach disinfects surfaces but is not a routine patient contact intervention. Using bleach on every surface is impractical, and surfaces alone do not represent the highest volume transmission link compared to healthcare worker hands. Hand hygiene is the single most effective infection control intervention in clinical care. It works by interrupting the chain of infection at the point where healthcare worker hands carry organisms from one patient or surface to the next. The chain of infection has 6 links. Hand hygiene targets the mode of transmission, the link where transient organisms on healthcare worker hands travel from one patient to the next before being deposited. The World Health Organization defines 5 moments requiring hand hygiene: before touching a patient, before a clean or aseptic procedure, after body fluid exposure, after touching a patient, and after touching patient surroundings, Glove removal adds a sixth critical moment. Alcohol-based hand rub covers most clinical moments and requires 15 to 20 seconds of rubbing. However, soap and water is required when hands are visibly soiled and always for Clostridioides difficile, because alcohol cannot inactivate C. Difficile spores, only mechanical removal with soap and water works. Remember, gloves reduce organism transfer but never replace hand hygiene. Microperforations allow contamination during use, and doffing can transfer organisms to the hands. Hand hygiene after glove removal is always required, no exceptions. Question 26. A PCT is helping a nurse use a portable fire extinguisher to put out a small contained fire in a soiled utility room. The PCT recalls the PASS acronym for extinguisher operation. After pulling the safety pin, where on the fire should the nozzle be aimed? Your options are A. At the top of the flames, B. Above the smoke column, C. At the base of the fire, D. At the patient room nearby. Take a second. Which answer would you pick? The correct answer is C. At the base of the fire. C is correct because the A in PASS stands for aim, with the nozzle directed at the base of the fire where the fuel is burning. Aiming at flames or smoke alone wastes the extinguishing agent without reaching the source. A is wrong because aiming at the top of the flame sends the agent through the visible fire without reaching the burning fuel. Flames re-establish themselves immediately because the source is still fed by the unburned material at the base. B is wrong because smoke is the byproduct of combustion, not the source. Spraying above the smoke wastes capacity entirely, since the agent never reaches the fuel that is creating the fire and continues to burn underneath. D is wrong because aiming at a nearby patient room would not extinguish the fire and could spread the agent into a clean area. The extinguisher must be directed at the burning material itself, never at a different room or area. When operating a portable fire extinguisher, every action follows the PASS acronym. This four-step sequence ensures the agent is released correctly and directed where it can actually stop combustion. Pull removes the safety pin to unlock the handle. Aim points the nozzle at the base of the fire, not the flames, not the smoke. Squeeze releases the extinguishing agent. Sweep moves the nozzle side to side to coat the entire fuel base. Aiming at the base smothers the combustion reaction at its source. Directing agent at the visible flames lets them re-establish the moment the agent passes through. Spraying at smoke wastes the entire charge because smoke contains nothing burnable. The sweep step distributes agent evenly across the full width of the burning area. A stationary stream exhausts the extinguisher before covering all the fuel. Continuous side-to-side passes deprive the entire fuel base of the oxygen and heat needed to sustain combustion. A common mistake is confusing PASS with RACE, which stands for rescue, alarm, contain, and extinguish or evacuate. RACE governs what you do first when a fire is discovered. PASS governs only the physical operation of the extinguisher once you have it in hand. Question 27. A PCT is reviewing the PASS acronym for portable fire extinguisher use during fire safety training. The instructor asks which step S the operator performs after squeeze. Which action best matches the second S in the PASS acronym during use of the device? Your options are A. Stand back from the fire base, B. Spray upward towards smoke column, C. Stop after one short burst, D. Sweep side to side at the base. Before I reveal it, which one do you think is right? The correct answer is D. Sweep side to side at the base. D is correct because the second S in PASS is sweep, where the nozzle moves side to side across the base of the fire. This distributes the agent evenly across the fuel and prevents leaving unburned material that could reignite. A is wrong because stand back from the base is positional advice, not a step in PASS. The acronym specifies pull, aim, squeeze, Sweep and stand back distance is implied during operation, but is not the literal letter of the second ts. B is wrong because spray upward towards the smoke column wastes the agent because smoke is not the fuel. The proper sweep is at the base of the fire, side to side, where the burning material is, not toward the smoke. C is wrong because stop after one short burst is not part of the acronym. The recommendation is to sweep continuously while squeezing the handle so the agent reaches the entire base of the fire effectively during the discharge. When using a portable fire extinguisher, the PASS acronym gives you 4 precise steps to follow. Each step serves a distinct purpose, and skipping or confusing any one of them can cause the extinguisher to fail. Pull removes the safety pin to unlock the trigger. Aim directs the nozzle low toward the base of the fire. Squeeze releases the extinguishing agent. And sweep moves the nozzle continuously from side to side across the entire fire base during discharge. The sweep is a motion, not a fixed position. By moving the nozzle from left to right and back again while maintaining discharge, the agent progressively coats the entire fire base rather than concentrating in one spot while adjacent fuel keeps burning. A stationary squeeze concentrates the agent in one area while adjacent burning material continues to combust. The sweep solves this by distributing the agent across the full base throughout the entire discharge, maximizing coverage within the extinguisher's limited capacity. A key exam trap is misidentifying the final S. Stop, stand back, and spray upward are all incorrect. Only sweep side to side describes the actual delivery motion that ensures the extinguishing agent reaches all burning fuel at the base. Question 28. A PCT is asked to take a verbal order from a provider over the phone for a routine medication change. The PCT is not authorized to take medication orders. Which response demonstrates the proper application of scope of practice and chain of command? Your options are A. Refer the provider to the nurse. B. Take the order verbally and inform later. C. Document and execute as told. D. Promise to relay it accurately. What's your answer? Commit to one before I continue. The correct answer is A. Refer the provider to the nurse. A is correct because verbal medication orders are accepted only by licensed staff who can act on them, typically the nurse. The PCT redirects the provider to the nurse so the order is taken correctly with readback and documented. B is wrong because taking the order verbally and informing later places the PCT outside scope and risks transcription errors. The redirect to the nurse during the call avoids the gap and ensures proper readback by authorized staff. C is wrong because documenting and executing as told would be acting on a medication order, which the PCT cannot do. Even if the wording was clear and accurate, the action itself is outside scope and exposes the patient to risk. D is wrong because promising to relay accurately turns the PCT into an unofficial messenger and increases the chance of misunderstanding. The proper handoff is direct provider to nurse, with the PCT facilitating the connection rather than acting as the relay link. When a provider calls and attempts to give a verbal medication order, the PCT's scope of practice determines exactly what happens next. Scope defines the boundaries of clinical activity that a credential and role authorize. And for PCTs, verbal medication orders fall outside those boundaries entirely. There are 3 reasons this boundary exists. PCTs cannot assess whether a medication order is appropriate for a patient's current status, cannot perform the readback verification required by Joint Commission standards, and do not hold the documentation authority to enter a verbal order into the medical record. The Joint Commission requires that verbal orders flow directly from provider to licensed nurse, written in real time, then read back for confirmation before the call ends. The PCT's correct action is to redirect the provider to the nurse immediately, never writing the order down to relay it later. When a provider reaches a PCT by mistake, the PCT does not take the order, does not write it down to hand off later, and does not promise to relay it. Instead, the PCT redirects the provider to the nurse, who receives, documents, and reads back the order. Then the PCT logs that the provider was connected. Remember, the scope boundary is specific to medication orders and other orders requiring licensed clinical judgment, not to all provider communication. A provider asking a PCT to reposition a patient is within scope. A verbal medication order never is. Question 29. A PCT is reviewing the level of biohazard label that should appear on items in the workplace per OSHA. According to the bloodborne pathogen standard, which color and symbol must appear on containers used to hold regulated medical waste in the facility? Your options are A. Green container with recycle arrow. B. Orange or orange-red biohazard symbol. C. Blue container with caution stripes. D. Black container with skull symbol. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Orange or orange-red biohazard symbol. B is correct because OSHA requires biohazard labels in orange or orange-red with the universal biohazard symbol on containers, refrigerators, and storage holding blood, open or contaminated items. Red bags with the biohazard symbol may substitute for the label. A is wrong because green containers with a recycle arrow are for recyclable materials. They have no role in regulated medical waste, and using them would route biohazard items through a stream that does not include the required treatment steps. C is wrong because blue containers with caution stripes are not the standard for biohazard labeling. The orange or orange-red biohazard symbol is the OSHA-defined visual cue, and substituting blue would fail the labeling requirement entirely. D is wrong because black containers with skull symbols typically indicate hazardous chemical waste under different rules. Bloodborne pathogen containers use the orange biohazard symbol rather than skull imagery, which is reserved for acute toxicity or chemical hazards. OSHA's bloodborne pathogens. Standard mandates specific warning labels on any container holding blood, blood products, or other potentially infectious materials. The purpose is simple. Workers must be warned at first contact before they ever open or inspect a container. A compliant label must include three elements: the orange or orange-red color, the universal biohazard symbol, the three-lobed trefoil design recognized internationally since the 1960s, and the word biohazard. All three together make the label valid under OSHA's standard. Red bags with the biohazard symbol permanently printed are also accepted as an equivalent to labeled containers, specifically for regulated medical waste disposal, giving facilities a practical alternative for waste bags and sharps containers. The standard covers a broad range of containers in any clinical setting. Sharps containers, specimen transport bags, refrigerators holding blood or OPM, and regulated medical waste bags all require the orange biohazard label or an equivalent red biohazard bag. The exam trap is substituting another warning color. Green, blue, black with skulls, and white GHS labels each belong to different regulatory systems. None of them satisfy the OSHA bloodborne pathogen standard. Only orange or orange-red with the biohazard symbol and text meets this specific requirement. Question 30. A PCT is asked about hand washing duration with soap and water. According to CDC guidance, what is the minimum scrubbing time required for soap and water hand hygiene to remove organism effectively from the hands during routine clinical work? Your options are A. 5 seconds of scrubbing, B. 10 seconds of scrubbing, C. 20 seconds of scrubbing, D. 60 seconds of scrubbing. Which would you go with? Lock it in before the reveal. The correct answer is C. 20 seconds of scrubbing. C is correct because CDC recommends scrubbing for at least 20 seconds with soap and water during routine hand hygiene. This is roughly the time required to sing Happy Birthday twice, ensuring adequate friction time on all surfaces. A is wrong because 5 seconds is far too short to remove organisms effectively. Quick rinses without sustained friction leave most pathogens on the hands. And the standard exists because longer contact time is needed for adequate removal. B is wrong because 10 seconds is also below the recommended duration. The science behind hand hygiene supports 20 seconds of mechanical friction for adequate organism removal during routine clinical care between patients on the unit. D is wrong because 60 seconds is longer than the routine standard for soap and water. While not harmful, it is more than required, and the recommended duration of 20 seconds at minimum is the answer for routine care. Effective hand hygiene isn't just about using soap, it's about how long and how thoroughly you scrub. The CDC's 20-second minimum exists for a precise scientific reason rooted in mechanics, not chemistry. Friction is the true engine of organism removal. Soap reduces surface tension and lifts microorganisms away from the skin, but it's the rubbing motion that physically displaces and carries them off into the rinse water. 20 seconds is the minimum needed to systematically contact every surface: the palms, backs of hands, between the fingers, around the thumbs, and under the fingernails. Shorter scrub times simply miss these zones, leaving organisms behind. The two methods are not interchangeable. Soap and water is required for visible soiling, C, difficile spores and norovirus outbreaks. Alcohol-based rub is preferred for routine decontamination when those conditions are absent. Both take roughly 15 to 20 seconds, but the situations differ critically. Remember, 5 seconds is a rinse, 10 seconds misses the fingers and nails, and 20 seconds is the floor that guarantees comprehensive friction across all hand surfaces. When the question asks for the minimum scrubbing time, the answer is always 20 seconds. Question 31. A PCT is reviewing the cardiac conduction system during EKG training. The instructor describes a structure in the right atrium near the superior vena cava that initiates each normal heartbeat. The PCT recalls intrinsic rates. Which structure and rate match this dominant pacemaker? Your options are AAV node 40 to 60, BSA node 60 to 100, C bundle of his at 50 to 70, D Purkinje fibers at 20 to 40. Don't overthink it. Which one feels right? The correct answer is B, SA node 60 to 100. B is correct because the sinoatrial node sits in the right atrium near the superior vena cava and is the dominant pacemaker with an intrinsic rate of 60 to 100 per minute in healthy adults at rest. A is wrong because the AV node is the backup pacemaker located in the interatrial septum and fires at 40 to 60 per minute when the SA node fails. It is not the dominant pacemaker described in this scenario. C is wrong because the bundle of his does not have a typical 50 to 70 intrinsic rate cited in standard text. The bundle of his conducts impulses below the AV node rather than serving as a primary pacemaker source for the heart. D is wrong because Purkinje fibers fire at 20 to 40 per minute as the slowest backup pacemaker. They are not the dominant pacemaker and only take over when both SA and AV nodes have failed during severe conduction disease. The sinoatrial node is the heart's dominant pacemaker, not because it was assigned that role, but because it fires faster than any other pacemaker structure. Understanding why it dominates, where it sits, and how its rate is controlled explains the foundation of normal cardiac rhythm. The SA node sits in the upper right atrium at its junction with the superior vena cava. It is a cluster of specialized cells capable of spontaneous depolarization. WACT. They generate their own action potential without any external stimulus, reaching threshold through a slow inward current. The SA node dominates because it fires at the fastest intrinsic rate, 60 to 100 beats per minute. The AV junction backs up at 40 to 60 and the ventricular Purkinje system at 20 to 40. The fastest rate wins, suppressing all slower pacemakers through overdrive suppression. The SA node rate is continuously shaped by the autonomic nervous system. Sympathetic input from exercise, fever, anxiety, or catecholamines speeds it up. Parasympathetic input through the vagus nerve slows it down. This is why a stressed patient may show sinus tachycardia that resolves once the stressor is removed. The most common exam trap is confusing the SA node with the AV node. The AV node is not the primary pacemaker. It is the gatekeeper that delays the impulse so the atria can finish contracting before the ventricles fire. The SA node generates the rhythm. The AV node controls its timing. Question 32. A PCT is taking vital signs on a patient with a known irregular heart rhythm. The radial pulse feels uneven and inconsistent. To document the most accurate heart rate for this patient, what should the PCT do when counting the rate? Your options are A. Count for 15 seconds and multiply. B. Take the rate from the monitor display. C. Use the carotid pulse instead. D. Apical pulse for 1 full minute. Got a guess? Lock it in. The correct answer is D. Apical pulse for 1 full minute. D is correct because apical pulse counted for 1 full minute is the most accurate method for irregular rhythms. Shorter counts at distant sites miss beats that are too weak to perfuse to the radial artery. A is wrong because counting 15 seconds and multiplying assumes the rate stays steady across the minute. With an irregular rhythm, the count varies second to second, so this approach produces an inaccurate documented rate. B is wrong because monitor displays should be verified, not trusted blindly, because lead artifact and arrhythmia detection algorithms commonly miscount in irregular rhythms. The PCT must take an apical pulse manually for accuracy. C is wrong because the carotid pulse is reasonable for emergencies but not the standard for routine documentation, and it shares the same problem of missing weakly perfused beats that the radial site has. When a patient has an irregular heart rhythm, the standard radial pulse count isn't reliable. Some beats contract with so little force that they never reach the wrist, but they still happen. And they still count. The radial artery only receives beats with enough stroke volume to perfuse the periphery. In atrial fibrillation, early or poorly filled beats are audible at the apex, but produce no palpable wave at the wrist. So the radial count systematically undercounts the true heart rate. The stethoscope diaphragm is placed at the 5th intercostal space along the left midclavicular line, directly over the ventricular apex. Here you hear each lub-dub pair, first heart sound, then second heart sound, and each pair equals 1 complete heartbeat. You must count for a full 60 seconds because the rate varies beat to beat in an irregular rhythm. A 15-second count multiplied by 4 assumes a constant rate that simply does not exist. Only the full minute apical count removes sampling error and gives an accurate documented rate. Remember, irregular rhythm means apical pulse for 1 full minute. It's TEs, not the radial count, not the monitor display. That single technique is the gold standard for documentation when the rhythm is known to be irregular. Question 33. A PCT receives a verbal report from an off-going co-worker describing a patient with new shortness of breath, oxygen saturation of 88 on room air, and recent productive cough. The ongoing PCT must act based on this report. Which is the correct first action for the ongoing PCT? Your options are A. Wait for the next round to assess. B. Document the verbal report only. C. Notify the nurse promptly and assess. D. Page the resident on call directly. Which one is it? Pause the video if you need more time. The correct answer is C. Notify the nurse promptly and assess. C is correct because oxygen saturation below 90% with new respiratory symptoms requires nurse notification immediately. The PCT also assesses the patient, monitors vitals, and stays with the patient until the nurse evaluates and determines next steps. A is wrong because waiting for the next round delays evaluation of a patient already meeting reportable criteria. Oxygen below 90% with new symptoms can deteriorate quickly, and routine wait and see is not appropriate for this presentation. B is wrong because documenting the verbal report alone leaves the patient without a nurse evaluation. Documentation supports the report, but cannot replace the conversation with the nurse and bedside assessment that the situation clearly requires. D is wrong because paging the resident directly skips the chain of command in most facilities. The nurse is informed first because nurses coordinate the bedside response and decide whether and how to escalate further to the medical team. When a patient's condition is identified during handoff, the incoming provider inherits both the information and the obligation to act on it. Understanding why handoff matters, and when it demands immediate escalation, is the core clinical judgment skill being tested here. A complete handoff gives the incoming provider 4 things: current status, outstanding needs and recent changes, anticipated events, and any threshold findings that require immediate action. The Joint Commission identifies failed handoff as one of the most common root causes of serious patient safety events. When a threshold finding is identified, the PCT's role is straightforward: assess the patient, notify the bedside nurse immediately, and stay until the situation is evaluated and stabilized. The nurse is the designated first point of escalation. The PCT does not skip the nurse to contact a physician directly. The key distinction is the severity threshold. An oxygen saturation of 96% with no new symptoms calls for documentation and routine communication. A saturation below 90% with new respiratory symptoms crosses the threshold for immediate notification, regardless of whether the PCT observed it directly or received it in handoff. Waiting for the next scheduled assessment, simply documenting the handoff report, or repositioning and watching longer are all forms of deferral, and all represent failures to respond to an already identified threshold event. The information source never changes the obligation to escalate. Questioner 34. A PCT collects a specimen and notices that the gold SST tube was filled, capped, and immediately set aside on a tray for transport without inversion. The PCT recalls the consequences. What is the likely outcome of skipping the inversion on a gold SST tube? Your options are A. Hemolysis from incomplete clotting and fibrin formation. B. Increased glycolysis and falsely lower glucose. C. Microclots in the EDTA fraction. D. Specimen freezes more rapidly. Take a second. Which answer would you pick? The correct answer is A. Hemolysis from incomplete clotting and fibrin formation. A is correct because gold SST tubes contain a clot activator that must be mixed evenly. Skipping inversion produces incomplete clotting with fibrin strands forming after centrifugation, which clogs analyzers and causes erroneous chemistry results. B is wrong because glycolysis affects glucose preservation in tubes lacking fluoride, but the gold tube does not contain fluoride to begin with. Skipping inversion in gold causes fibrin issues, not glycolysis-related glucose problems specifically. C is wrong because EDSA microclots occur in lavender tubes that are not inverted. Gold tubes do not contain EDSA, so skipping inversion in gold produces clot-activated distribution problems rather than EDTA microclot formation. D is wrong because inversion does not affect freezing rate. Skipping inversion in gold tubes produces fibrin and clot activator issues, with no relationship to whether the specimen subsequently freezes during transport or storage. When a gold SST tube is not inverted after collection, the clot activator stays concentrated at the bottom instead of contacting all the blood evenly. This uneven distribution is the root cause of a chain of pre-analytical errors that can compromise an entire batch of chemistry results. In a properly mixed SST tube, silica clot activator contacts all the blood, producing a uniform clot. When the tube sits uninverted, clot activator stays at the bottom, leaving the upper blood to clot poorly. After centrifugation, the poorly clotted portion releases loose fibrin strands into the serum layer. Fibrin in serum causes real clinical disruption. It can clog analyzer probes, forcing a repeat of every patient in that batch. Certain analytes may read falsely high or low depending on how fibrin binds them. The specimen can look visually clear yet still carry fine strands, so the lab must reject it and request a fresh draw. Each tube type has its own mixing failure consequence. The SST gold tube produces fibrin when not inverted. Lavender EDSA tubes develop microclots because EDSA cannot chelate calcium. Grey fluoride tubes allow glycolysis to continue before fluoride inhibits enolase. And over-vigorous mixing of any tube causes hemolysis, a completely separate error from missing an inversion. The exam key is simple. A gold SST tube left uninverted produces fibrin, not hemolysis. Hemolysis comes from trauma or overmixing. Fibrin is the SST-specific consequence of missing those gentle inversions right after collection. Question 35. A PCT measures urinary output for an adult patient over the past 2 hours and finds totals of 20 milliliters and 22 milliliters. The patient is alert and reports normal fluid intake during the shift. What is the most appropriate action? Your options are A. Document and recheck on the next shift. B. Increase oral fluid intake by 2 cups. C. Notify nurse promptly about low output. D. Reposition and reassess in another hour. Before I reveal it, which one do you think is right? The correct answer is C. Notify nurse promptly about low output. C is correct because output below 30 milliliters per hour for 2 consecutive hours is a reportable finding for adult patients. Persistent low output may signal dehydration, hypoperfusion, or evolving kidney injury and needs nurse evaluation now. A is wrong because waiting until the next shift delays recognition of a finding that already meets the 2-hour reportable threshold. The pattern of low output deserves immediate attention, not silent documentation that hands the issue forward. B is wrong because increasing oral fluids without nurse evaluation may be inappropriate for some patients, including those with heart failure or renal disease. The PCT must escalate first so the cause can be assessed before changing fluid intake. D is wrong because repositioning and waiting another hour stretches the period of unexplained oliguria. By the time the 3rd hour ends, 3 hours of low output have passed, and intervention windows for some causes are narrowing further. Monitoring urinary output gives us real-time information about how well the kidneys are being perfused. Because the kidneys receive roughly 20% of cardiac output, a drop in perfusion from any cause shows up quickly as reduced urine production, often before blood pressure or heart rate even change. The benchmark is 30 milliliters per hour. When output falls below this for 2 consecutive hours, shots meaning less than 60 milliliters total, that meets the clinical definition of oliguria. At that point, the PCT must notify the nurse immediately, not wait for the next scheduled assessment round. The kidneys are highly sensitive perfusion monitors. Blood flows from the heart through the renal arteries, and the kidney filters it through glomerular filtration and tubular reabsorption. Any disruption, dehydration, hemorrhage, heart failure, or sepsis, reduces that flow and cuts urine production rapidly. Oliguria can stem from several serious underlying causes: dehydration, hemorrhage, heart failure, or sepsis-related hypoperfusion. This is why the PCT cannot simply encourage oral fluids and move on. In heart failure, adding fluid can worsen elevated filling pressures, and in renal failure it may not be excreted at all. The key exam principle is this: the output number is the clinical signal. A patient who feels fine can still be in early hypoperfusion. 2 consecutive hours, each below 30 milliliters per hour, means the PCT notifies the nurse promptly with the 2-hour totals and latest vital signs in hand. Question 36. A PCT is observing a sterile dressing change. The nurse pours sterile saline from a bottle into a sterile basin on the field. The PCT recalls that there is a step before pouring into the basin that the nurse must perform to maintain sterility. Your options are: A. Wipe the bottle lip with sterile gauze. B. Pre-warm the bottle in microwave. C. Soak the bottle cap in alcohol. D. Pour off small amount of saline first. What's your answer? Commit to one before I continue. The correct answer is D. Pour off small amount of saline first. D is correct because the bottle lip is considered contaminated. The nurse pours a small amount of saline onto a non-sterile surface to flush the lip first, then pours the rest into the sterile basin without letting the bottle touch. A is wrong because wiping the bottle lip with sterile gauze does not remove organisms from a non-sterile bottle exterior reliably. The standard step is to pour off a small amount to flush the lip rather than wiping it with gauze. B is wrong because pre-warming the bottle in a microwave is not a sterility step and is unsafe for many fluids. The relevant step before pouring into the basin is the flush of the lip, not any heating preparation step. C is wrong because soaking the cap in alcohol does not address the bottle lip and is not part of the procedure. The standard is to pour off a small amount to clear the lip rather than acting on the cap. Sterile technique is built on one core principle. Contamination flows from non-sterile to sterile, never the reverse. Understanding why nurses pour off saline before filling a sterile basin requires knowing where contamination actually hides. Even a sealed saline bottle has a non-sterile exterior. The bottle lip, the rim the liquid crosses when poured, has been exposed to organisms. Pouring directly from an unrinsed lip into a sterile basin risks riding those organisms right into the sterile field. The pour-off step works by rinsing the bottle lip with the first small volume of saline, directing it away from the sterile field onto a non-sterile surface. The remainder then flows from a clean lip into the sterile basin. The bottle itself never touches the basin or the sterile field. Wiping the lip with gauze is a common intuitive response but is not correct technique. Wiping may redistribute organisms rather than remove them, and even sterile gauze becomes contaminated the instant it contacts the non-sterile bottle. The pour-off method is the reliable, documented standard. When a question asks what action a nurse takes before pouring saline into a sterile basin, the answer is always the pour-off step. Checking the label and expiration are important, but test a different concept entirely. The lip flush pour-off is the specific procedural detail being examined. Question 37. A PCT is calculating heart rate from a regular EKG rhythm strip using the 1500 method. The PCT counts 20 small boxes between 2 consecutive R waves on the strip. Which heart rate is calculated using this method based on the count obtained from the strip? Your options are A. 75 beats per minute, B. 60 beats per minute, C. 100 beats per minute, D. 50 beats per minute. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. 75 beats per minute. A is correct because the 1500 method divides 1500 by the number of small boxes between R waves for regular rhythms. 1500 divided by 20 equals 75 beats per minute, which is within the normal sinus range. B is wrong because 60 beats per minute would correspond to 25 small boxes between R waves under the 1500 method. 20 small boxes calculates to 75. So 60 is not the right answer for this specific count. C is wrong because 100 beats per minute would correspond to 15 small boxes between R waves. 20 small boxes is wider than that, indicating a slower rate. So 100 overestimates the rate from the count provided. D is wrong because 50 beats per minute would correspond to 30 small boxes between R waves, not 20. The math for the 1500 method gives a different rate at 20 small boxes, so this answer is not correct here. The 1500 method is a precise way to calculate heart rate from a regular EKG rhythm. It works because at standard paper speed, there are exactly 1500 small boxes in 1 minute of EKG recording, each representing 0.04 seconds. To use this method, find two adjacent R-wave peaks on the strip and count the small boxes between them. Then divide 1500 by that count. For example, 20 small boxes between R waves gives a heart rate of 75 beats per minute. The relationship is constant and scales predictably. 15 small boxes gives 100 beats per minute, 20 gives 75, and 30 gives 50. Any regular rhythm can be calculated this way as long as two clean R peaks are identifiable. The most common exam trap is mixing numerators with the wrong box size. 1500 pairs with small boxes and 300 pairs with large boxes. Swapping them produces wildly inaccurate rates. Always match the numerator to the box size being counted. Remember, the 1500 method is only valid for regular rhythms. For irregular rhythms, use the 6-second strip method instead. When applied correctly, both the 1500 and 300 methods will give the same heart rate. Question 38. A PCT is reviewing the lead positions for additional right-sided leads when right ventricular MR is suspected with an inferior STEMI presentation in the emergency department. Which right-sided lead is most clinically important to obtain quickly? And what does its ST elevation indicate diagnostically? Your options are A. V1R, left atrial enlargement, B. V4R, right ventricular MR, C. V5R, pericardial effusion, D. VSAR, posterior STEMI. Which would you go with? Lock it in before the reveal. The correct answer is B. V4R, right ventricular MR. B is correct because V4R is placed at the 5th intercostal space at the right midclavicular line. A ST elevation of 1 millimeter or more in V4R is diagnostic of right ventricular MR, often associated with inferior STEMI from RCA occlusion. A is wrong because V1R is not a recognized standard right-sided lead, and left atrial enlargement is assessed from P-wave morphology in V1 and 2. The most clinically important right-sided lead in suspected RVMR is V4R, not V1R. C is wrong because V5R is not the standard right-sided lead used to diagnose RVMR, and pericardial effusion shows electrical alternans rather than focal ST changes. The standard is V4R, with V5R rarely tested or used. D is wrong because V7R is not standard. Posterior STEMA uses V7, V8, and V9 placed on the back. RVMR is diagnosed using V4R, and the posterior leads address a different territory entirely on the heart. When an inferior STEMI involves the right coronary artery, the right ventricle itself can infarct simultaneously. Recognizing this early changes management entirely, because the right ventricle in this setting is preload dependent and cannot tolerate standard vasodilators or diuretics used for left-sided failure. The standard 12 lead simply doesn't include right ventricular leads. Inferior ST elevation alone cannot tell you whether the right ventricle is involved. You must add right-sided leads, and V4R, the single most sensitive lead, is your target. 1 millimeter or more of ST elevation in V4R during an acute inferior STEMI is diagnostic. V4R is placed at the 5th intercostal space along the right midclavicular line, the exact mirror image of standard V4, but on the right side of the chest. The remaining right-sided leads fan out symmetrically across the right chest wall. V4R ST elevation is transient. Within 12 to 24 hours of RCA occlusion, it typically resolves, even without reperfusion. Recording right-sided leads promptly in the emergency department captures the finding. Waiting until the next morning risks a normal tracing and a missed diagnosis. The classic exam trap is confusing right-sided leads with posterior leads. Posterior STEMI uses V7, V8, and V9 placed on the back of the left chest, and shows ST depression in V1 through V3 as a mirror image. Right ventricular MI uses right-sided leads, specifically V4R. Different territories, different lead placements, don't mix them up. Question 39. A PCT is asked about negligence and malpractice during an in-service. The instructor explains the 4 elements that must all be proven for negligence. Which combination correctly lists all 4 required elements that must be proven in a negligence case? Your options are A. Breach causation motive damages, B. Duty intent breach harm, C. Duty breach causation damages, D. Standard fault breach intent. Don't overthink it. Which one feels right? The correct answer is C. Duty breach causation damages. C is correct because negligence requires proof of all 4 elements: duty, breach of duty, causation linking the breach to harm, and damages. Missing any one element prevents a finding of negligence even when 1 or 2 elements are present. A is wrong because motive is not a legal element of negligence. The case turns on duty, breach, causation, and damages. Motive may surface in some cases, but it is not part of the 4-element test that determines liability for negligence. B is wrong because intent is an element of intentional torts, not negligence. Negligence is about a failure to meet a standard of care, not about intending to cause harm. So adding intent misclassifies the elements required for liability. D is wrong because standard and fault are general concepts rather than the formal 4 elements. The required list is duty, breach, causation, and damages, and substituting other terms produces an incomplete framework that cannot support a negligence claim in court. Negligence is a legal standard that establishes liability when a caregiver's failure to meet the standard of care causes patient harm. To succeed, a negligence claim requires all 4 elements to be proven independently. Duty is the legal obligation created when a patient enters the care relationship. Breach is the failure to meet what a similarly trained PCT would have done. Causation requires that the breach actually produce the harm, and damages are the physical, financial, or other losses the patient suffered as a result. In a real case, a PCT who skipped post-venipuncture pressure caused a hematoma requiring surgery. The care relationship established duty. Skipping the pressure step was the breach. The hematoma was directly caused by that breach, and the surgical costs and pain were the damages. All 4 elements were present and the case settled. Malpractice is negligence committed by a licensed professional. PCTs face negligence, not malpractice. Battery applies when a procedure is performed without consent. Intent is an element of battery and assault, not negligence. If an answer substitutes intent, motive, or fault as a named element, it is describing the wrong legal standard. Missing even one element defeats the entire claim. A breach without causation is not negligence. Harm without a breach is not negligence. The exact 4-element list is what the exam tests, and any answer with different terms is wrong. Question 40. A PCT is asked by a peer to share login credentials briefly to enter routine vital signs because the peer is locked out. According to the HIPAA security rule and standard credential policy, what is the appropriate response from the PCT receiving this request? Your options are A. Lend credentials briefly to help peer. B. Decline and direct peer to IT. C. Lend if peer signs an agreement. D. Share with verbal acknowledgement only. Got a guess? Lock it in. The correct answer is B. Decline and direct peer to IT. B is correct because login credentials are personal and never shared. The PCT declines and directs the peer to IT for an unlock or temporary access. Sharing credentials defeats the audit trail and violates technical safeguards under the security rule. A is wrong because briefly lending credentials still violates the policy and the audit trail. Any access during the loan is logged under the original PCT, who becomes accountable for whatever is documented or viewed during that session by the peer. C is wrong because an informal agreement does not legitimize credential sharing. The technical safeguard is identity-based, and no agreement between co-workers can override the institutional rule that each user uses only their own login at all times. D is wrong because verbal acknowledgement does nothing to protect the audit trail. The login still belongs to the PCT, and the peer's actions appear under the PCT's name, which is exactly what credential sharing rules prevent. The HIPAA security rule requires covered entities to protect electronic protected health information through specific safeguards. Login credentials sit at the center of that protection because they make every action in an electronic health record traceable to one accountable individual. The security rule organizes its protections into 3 categories: administrative, physical, and technical safeguards. Login credentials are a technical safeguard, and their specific function is to ensure every recorded action is attributable to the authorized person who actually performed it. The audit tray is the legal and accountability record of who accessed, created, modified, or transmitted patient information. When someone borrows another person's credentials, every action logs under the wrong name, creating a false record that cannot identify the actual person if a breach or error occurs. Sharing credentials produces 4 serious consequences. The audit trail records the wrong name, errors are misattributed to an innocent person, breaches become untraceable, and the credential owner faces disciplinary action for actions they never performed. The correct response is always to decline and direct the coworker to IT, which maintains processes for emergency account unlocks and temporary supervised access. Remember, the audit trail does not capture how long credentials were shared. It only captures the actions taken. So even a brief loan creates identical regulatory liability. Question 41. A PCT is helping prepare a patient for surgery in the holding area. The team is about to begin the timeout portion of the universal protocol. During the timeout, who should be actively involved in confirming the correct patient, site, and procedure? Your options are A. Only the lead surgeon and patient. B. Only nurses and PCT in the bay. C. Anesthesia and circulating nurse alone. D. All team members participating in the procedure. Which one is it? Pause the video if you need more time. The correct answer is D. All team members participating in the procedure. D is correct because the Universal Protocol timeout requires all team members participating in the procedure to actively confirm correct patient, correct site, and correct procedure. Any disagreement halts the procedure until the issue is resolved. A is wrong because limiting timeout to surgeon and patient leaves nursing and anesthesia silent. Each role observes different details and may catch a discrepancy the surgeon does not. So excluding them from active participation defeats the protocol's purpose. B is wrong because excluding the surgeon and anesthesia leaves out the people most accountable for the procedure itself. The protocol is designed for shared verification across all roles, not for any single discipline to confirm everything alone. C is wrong because anesthesia and circulating nurse alone do not represent the full team. The lead surgeon, the patient when feasible, and other staff in the room are all part of the active confirmation step required by the protocol. The Universal Protocol is a patient safety standard created by the Joint Commission to prevent wrong patient, wrong site, and wrong procedure surgeries. It has 3 distinct components, each acting as a checkpoint before a procedure begins. The 3 components are pre-procedure verification, which occurs throughout the perioperative period, site marking, performed by the surgeon before the procedure, and the timeout, conducted immediately before incision with the full team assembled. The timeout is not a form someone checks off or a surgeon announcement. Every team member, surgeon, anesthesiologist, circulating nurse, and scrub technician must verbally confirm the correct patient, correct procedure, and correct site. If anyone disagrees, the procedure does not begin. Each discipline notices different things. The anesthesiologist may catch an allergy mismatch. The circulating nurse may spot a wrong site marking. And the scrub technician may notice the instrument tray is set up for the wrong side. No single person can catch every error, which is why all must participate. The most common exam trap is limiting participation to a subset of the team. Surgeon and patient only, nurses and PCTs only, or anesthesia and circulating nurse only. All miss required participants. Only active verbal confirmation by all team members present meets the Universal Protocol standard. Question 42. A PCT is preparing to draw blood on a patient who states that she is sensitive to latex, with a history of swelling and itching after past contact. The PCT must select supplies. Which combination is appropriate to use during this collection given the latex sensitivity? Your options are A. Latex-free gloves and tourniquet. B. Latex-free gloves only with latex tourniquet. C. Latex gloves and a Velcro tourniquet. D. Powder-free latex gloves only. Take a second. Which answer would you pick? The correct answer is A. Latex-free gloves and tourniquet. A is correct because patients with latex sensitivity require latex-free supplies including gloves and tourniquet. Even a latex tourniquet may trigger a reaction, so the entire kit is selected to be latex-free for these patients during routine venipuncture procedures. B is wrong because mixing latex-free gloves with a latex tourniquet still exposes the patient to latex contact at the upper arm. The tourniquet must also be latex-free to fully protect a sensitive patient during the draw. C is wrong because latex gloves on a latex-sensitive patient are clearly inappropriate. Even with a Velcro tourniquet, the gloves are in direct contact during venipuncture, and any latex element risks triggering a reaction in this patient. D is wrong because powder-free latex gloves still contain latex protein. Powder-free reduces airborne latex exposure but does not eliminate skin contact with latex, so they remain unsuitable for a known latex-sensitive patient during the procedure. When a patient has a latex allergy, a single item swap is never enough. The underlying principle is complete substitution. Every latex-containing component in the phlebotomy setup must be identified and replaced before the procedure begins. Latex proteins are found in multiple components of a standard phlebotomy setup: gloves, tourniquets, rubber tube stoppers, and the tops of certain specimen tubes. A tourniquet pressed against skin for 60 to 90 seconds is a significant dermal exposure, enough to trigger a systemic reaction in a sensitized patient. The allergy spectrum matters clinically. Contact dermatitis is a delayed hypersensitivity reaction causing localized irritation. True IgE-mediated hypersensitivity is immediate and can escalate to urticaria, bronchospasm, and full anaphylaxis within minutes, which is why incomplete protection is dangerous. The correct kit includes nitrile, vinyl, or neoprene gloves and a silicone or Velcro tourniquet. Both must be latex-free. Note that powder-free latex gloves reduce airborne allergen, but still contain latex protein in direct contact with skin, making them inappropriate for a documented latex allergy. The classic exam mistake is swapping the gloves while keeping a latex tourniquet, replacing what the PCT touches, not what touches the patient. Complete substitution means every item contacting a latex-sensitive patient must be latex-free, no exceptions. Question 43. A PCT enters a room and finds a post-operative patient slumped in bed and unresponsive. The PCT taps the patient's shoulder and shouts the name with no response. What is the correct sequence of next actions according to the basic life support sequence for healthcare providers? Your options are: A. Place the patient in recovery position first. B. Begin compressions immediately at 100 per minute. C. Open airway and give 2 breaths. D. Activate emergency response, get AED, check pulse. Before I reveal it, which one do you think is right? The correct answer is D. Activate emergency response, get AED, check pulse. D is correct because after confirming unresponsiveness, the provider activates the emergency response, sends for the AED, then checks pulse and breathing simultaneously for no more than 10 seconds before starting compressions if needed. A is wrong because recovery position is for unresponsive patients who are breathing normally, not for an unwitnessed, unresponsive patient who may be in cardiac arrest. Placing the patient in recovery position delays activation and possible defibrillation. B is wrong because beginning compressions before activating help leaves the team without an AED and without the broader emergency response. The pulse check is also skipped, so the rescuer might be doing compressions on a patient who has a pulse. C is wrong because opening the airway and giving rescue breaths skips activation of the emergency response and the AED retrieval. Modern guidelines emphasize early defibrillation as the priority for adults in sudden collapse on the unit. Basic life support for healthcare providers follows a specific, order-dependent sequence designed to get the highest impact interventions in place within the first critical minutes of cardiac arrest. The order is not arbitrary. Each step sets up the one that follows. After confirming unresponsiveness by tapping and shouting, the provider simultaneously activates the emergency response and dispatches someone for the AED. These happen at the same moment, not in sequence. Only then does the pulse and breathing check occur, lasting no more than 10 seconds before compressions begin. Compressions alone cannot convert ventricular fibrillation. They provide circulatory support that keeps heart tissue viable long enough for the AED to work. Defibrillation is the only definitive treatment for ventricular fibrillation, and for every minute it is delayed without CPR, survival drops by approximately 10%. The most tested trap is starting compressions before activating the emergency response. This leaves the provider doing solo CPR without the AED or code team. A second trap is placing an unresponsive patient in recovery position, which is only appropriate when the patient is breathing adequately, not in suspected cardiac arrest. In any healthcare BLS scenario, Activation of the emergency response and retrieval of the AED must happen before or simultaneous with compressions, never after. The AED must be present and ready. Sustained solo compressions without it is the wrong answer. Question 4. A PCT is preparing the standard order of draw under CLSI GP41 for a multi-tube collection. The order list begins with sterile blood culture bottles. Which tube is the second to be filled in the standard order after blood cultures are completed? Your options are A. Light blue sodium citrate tube, B. Lavender etta tube, C. Gold serum separator tube, D. Grey sodium fluoride tube. What's your answer? Commit to one before I continue. The correct answer is A. Light blue sodium citrate tube. A is correct because after blood culture bottles, the second tube is light blue with sodium citrate. The order is yellow cultures, light blue, red or gold, green, lavender, then grey to prevent additive carryover between tubes. B is wrong because lavender etta is fifth in the order. Etta traces can falsely lower calcium and prolong coagulation tests, which is why it is positioned after the citrate, serum, and heparin tubes in the official sequence. C is wrong because gold serum separator is third. It comes after blood cultures and light blue but before green and lavender. Drawing it second would put a clot activator before the citrate tube, which alters coagulation results. D is wrong because grey sodium fluoride is last in the order. Its position after lavender minimizes carryover effects from the fluoride and oxalate, which can interfere with multiple chemistry tests if drawn earlier in the sequence. The order of draw is a standardized sequence for filling collection tubes during a single venipuncture. Its entire purpose is to prevent additive carryover. Trace amounts of one tube's additive contaminating the next tube and corrupting results. CLSI GP41 defines 6 positions. Blood cultures go first to prevent any additive contamination of the sterile inoculation. The light blue sodium citrate tube is always second. Before any serum, heparin, etta, or fluoride tube enters the line. Even a microscopic trace of clot activator carried from a gold SST tube into the citrate tube can partially trigger the coagulation cascade. This falsely shortens the PT and PTT, producing dangerously erroneous results for patients on warfarin or other anticoagulant therapy. Every position change has a specific consequence. Drawing the gold tube before light blue introduces clot activator. Heparin carryover into serum tubes disrupts chemistry assays. Etta chelates calcium and can falsely elevate potassium. Fluoride and oxalate go last because their interference potential is the broadest. The most common exam mistake is placing the citrate tube somewhere in the middle of the sequence. Its extreme sensitivity to clot activator contamination makes it the first non-sterile tube drawn. Fakusol always second, always immediately after blood cultures. Question 45. A PCT records a 12-lead EKG and notes ST elevation greater than 2 mm in leads V1 through V4. The patient has acute chest pain and diaphoresis. Which arterial territory matches this lead distribution, and what is the priority next step in care? Your options are A. Inferior wall RCA, observe and recheck. B. Lateral wall LCX, oral aspirin only. C. Anterior LAD, notify provider for urgent care. D. Posterior wall, await troponin result. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Anterior LAD, notify provider for urgent care. C is correct because ST elevation in V1 through V4 indicates an anterior wall stemming from LAD occlusion. The PCT notifies the provider immediately, so reperfusion therapy can be initiated, with door-to-balloon time targeted at 90 minutes or less. A is wrong because inferior wall RCA STEMI shows ST elevation in 2/3 and AVF, not V1 through V4. The lead distribution does not match the inferior territory, and observation alone is inappropriate for an active STEMI presentation regardless. B is wrong because lateral wall STEMI shows ST elevation in IAVL, V5 and V6. The pattern in V1 through V4 is anteroseptal rather than lateral, and oral aspirin alone falls short of the urgent reperfusion the patient needs. D is wrong because posterior STEMI shows ST depression in V1 through V3 with tall R waves, not elevation. The pattern described is anterior STEMI, and waiting for troponin would inappropriately delay urgent reperfusion therapy in this scenario. When an EKG shows ST elevation in a specific anatomical distribution, it triggers one of the most time-sensitive responses in clinical medicine. Understanding why requires knowing what the ST segment represents and how lead groupings map to heart territory. The ST segment falls between ventricular depolarization and repolarization. Normally it hugs the isoelectric baseline. When it rises 1 millimeter or more in two contiguous leads, that signals acute myocardial injury in the territory those leads overlie. The left anterior descending artery, the lead, supplies the anterior wall of the left ventricle, the muscle that sits directly beneath leads V1 through V4. Because the LAD feeds the largest territory of left ventricular muscle, occlusion here carries higher mortality than inferior or lateral infarction from a comparable clot. Lead groupings map directly to coronary territories. Elevation in V1 through V4 means anterior wall and LAD. Elevation in the inferior leads implicates the RCA. Lateral leads implicate the left circumflex. Critically, ST depression in V1 through V3 is a mirror image of posterior injury. The direction of deviation matters as much as the leads involved. The goal is reperfusion within 90 minutes of first medical contact. Door-to-balloon time is a publicly tracked quality metric, and every minute of delay means additional myocardial cell death. Recognizing the V1 through V4 elevation pattern and communicating it immediately makes the PCT a direct participant in saving that muscle. Question 46. A PCT is recording a 12-lead EKG on a patient with a permanent pacemaker. The PCT notices thin vertical lines preceding each QRS complex on the tracing. Which finding does this most likely represent, and what should the PCT do with the recording? Your options are A. Artifact from movement, redo tracing. B. Pacemaker spikes, document presence. C. AC interference, check ground. D. Premature ventricular contractions. Which would you go with? Lock it in before the reveal. The correct answer is B. Pacemaker spikes, document presence. B is correct because pacemaker spikes appear as thin vertical lines preceding the chamber being paced. The PCT documents the presence of pacing on the tracing, so the interpreter knows to read the EKG with that context. A is wrong because movement artifact appears as a regular trembling or shifting baseline rather than thin vertical spikes. Pacemaker spikes are sharp regular features tied to each QRS, and the situation calls for documentation rather than re-recording. C is wrong because AC interference appears as a uniform fast fuzz across all leads, not as thin vertical lines preceding each QRS. The two artifacts have different appearances, and the spikes here are pacemaker output, not electrical interference. D is wrong because premature ventricular contractions are early wide bizarre QRS complexes, not thin vertical spikes preceding QRS. The scenario describes pacemaker spikes, which is a normal feature for a PACE patient rather than a PVC pattern. When a patient has an implanted pacemaker, Every stimulus the device delivers leaves a visible mark on the EKG tracing. Understanding what those marks look like and what they mean is essential for any PCT recording cardiac tracings. A pacemaker spike appears as a narrow, high-amplitude vertical deflection, only 1 or 2 small boxes wide, immediately before the chamber it stimulates. Because ventricular depolarization travels cell to cell through muscle rather than the fast Purkinje system, the QRX that follows a ventricular spike is wide and broad, similar to a bundle branch block pattern. 3 findings are commonly confused. A pacemaker spike is a sharp, regular vertical line immediately before each QRS. Artifact appears as a regular baseline disturbance across all leads simultaneously, never a discrete spike. A premature ventricular contraction is an early wide QRS that arises on its own, with no preceding spike at all. The critical PCT action is documentation. The PCT notes that pacemaker spikes are present, that the patient has a known permanent pacemaker, and whether spikes precede every QRS complex or only some. This context allows the reading provider to distinguish paced rhythm from native rhythm and to evaluate whether the device is functioning correctly. A paced EKG is not a pathological finding, it is expected device output. Recognize the thin vertical spikes, complete the tracing, and document their presence so the interpreting cardiologist has the full clinical picture. Question 47. A PCT is reviewing OSHA exposure determination rules at orientation. The training module asks which document lists the job classifications with reasonably anticipated exposure to bloodborne pathogens. Which written facility document contains this list and must be updated annually? Your options are A. Exposure Control Plan document, B. Sharps Injury Log document, C. OSHA 300 log entries, D. Hazard Communication Plan only. Don't overthink it. Which one feels right? The correct answer is A. Exposure Control Plan document. A is correct because the Exposure Control Plan lists job classifications with anticipated exposure, methods of compliance, post-exposure procedures, and record keeping. It is reviewed annually and updated to reflect changes in tasks, devices, and the workforce. B is wrong because the Sharps injury log records actual Sharps injuries. It does not list job classifications with potential exposure and is a record-keeping document rather than a planning document like the Exposure Control Plan. C is wrong because the OSHA 300 log records work-related injuries and illnesses. It does not list job classifications with potential exposure, and the exposure determination lives in the Exposure Control Plan rather than the injury log. D is wrong because the Hazard Communication Plan covers chemical hazards under a different OSHA standard. It does not list bloodborne exposure job classifications, and the bloodborne pathogen exposure determination lives in the separate Exposure Control Plan. The OSHA bloodborne pathogen standard requires every covered employer to maintain a written exposure control plan, OMS, a living compliance document tailored to that specific workplace, not a generic template. The plan must include 4 core components: the exposure determination listing job classifications with anticipated blood contact, the engineering and work practice controls in use, the post-exposure follow-up procedure, and a record-keeping protocol. It must be reviewed and updated annually and whenever job tasks, classifications, or available safer devices change. The exposure determination section is the operational foundation of the entire program. It lists every job classification with reasonably anticipated exposure and the specific tasks that create that exposure. And this listing directly determines who receives free hepatitis B vaccination, annual training, PPE, and post-exposure follow-up. A common exam trap is confusing the Exposure Control Plan with other OSHA documents. The Sharps injury log records individual Sharps injuries after they occur. The OSHA 300 log records all work-related injuries and illnesses. Neither log lists job classifications with anticipated exposure. That is exclusively the role of the exposure control plan. When a question asks which OSHA document lists job classifications with anticipated bloodborne pathogen exposure, the answer is always the exposure control plan. Planning and recording are distinct functions served by two distinct required documents. Question 48. A PCT working in the lab specimen processing area is sticking a finger with a needle while disposing of a used sharp. The exposure is from a contaminated hollow bore needle. Following the OSHA exposure control plan, what is the very first step the PCT should take? Your options are: A. Squeeze the wound to express blood. B. Apply alcohol or bleach to the wound. C. Walk to employee health to report. D. Wash the area with soap and water. Got a guess? Lock it in. The correct answer is D. Wash the area with soap and water. D is correct because the first step after a percutaneous exposure is to wash the wound thoroughly with soap and water. Squeezing or applying caustic agents is not recommended. Reporting and post-exposure evaluation occur immediately after washing. A is wrong because squeezing the wound to express blood lacks evidence of benefit and may damage local tissue further. Current guidance is to wash with soap and water rather than try to milk the wound after a needle stick exposure occurs. B is wrong because alcohol or bleach on the wound is harmful and not part of any post-exposure protocol. Soap and water are the only recommended cleansers, and applying chemicals delays the rinse without offering any extra protection from infection. C is wrong because reporting comes immediately after washing, not before. Walking off without rinsing leaves contaminated material on the skin longer than necessary, while the standard sequence is wash first, then promptly report and seek evaluation. When a needle stick or percutaneous injury occurs, there is a specific sequence of actions that must happen in the correct order. Understanding the reasoning behind each step helps you apply the protocol correctly under pressure. The sequence begins with immediate wound washing using soap and water for several minutes. Reporting to a supervisor and proceeding to employee health happens right after washing, not instead of it. This order is not flexible. Soap and water works by physically removing and diluting the inoculum, the infectious material deposited by the needle. Running water combined with soap and gentle friction for several minutes is the standard first aid for any percutaneous bloodborne pathogen exposure. Squeezing or milking the wound has no proven benefit and can cause tissue damage. Caustic agents like bleach and hydrogen peroxide harm tissue without reducing infection risk beyond what soap and water already achieves. And reporting before washing wastes the most critical window for intervention. After washing and reporting, employee health evaluates the source patient's infection status and the worker's vaccination history. For hepatitis B, prophylaxis must begin within 24 hours. For HIV, antiretroviral post-exposure prophylaxis must start within 72 hours. Both clocks start at the moment of injury. Question 49. A PCT is asked to apply soft wrist restraints on a confused patient who is repeatedly pulling at a chest tube. The nurse has obtained an order. The PCT recalls the rule about how to tie restraints. Where should the restraints be secured to the bed? Your options are: A, to the side rails for quick access. B, to the headboard for stability. C, to the bed's movable frame. D, to the wheelbase for reach. Which one is it? Pause the video if you need more time. The correct answer is C, to the bed's movable frame. C is correct because restraint ties go to the movable bed frame, so they move with the bed when the head or foot is adjusted. Tying two side rails creates strangulation risk if the rail moves while the restraint stays fixed. A is wrong because side rails move when raised or lowered, so a fixed tie there can pull on the patient's wrist when the rail moves. Federal guidance specifically warns against this practice because it has caused asphyxia and entrapment injuries. B is wrong because the headboard is too far from the patient's wrist and is not designed as a tie point. Securing there limits range of motion and can pull awkwardly on the patient's arm during repositioning by the staff. D is wrong because the wheelbase is unstable and not the standard tie point. Securing there leaves the restraint loose during transport or even during routine bed adjustments, while the movable frame is the standard tie point chosen for safety. Soft wrist restraints are a common intervention in critical care, but where you tie them is just as important as how you apply them. The attachment point determines whether the restraint remains safe across every position change the patient goes through. The correct tie point is the movable bed frame, the structural element beneath the mattress that travels with the patient when the head or foot of the bed is raised. Because it moves with the bed, it never pulls the wrist from a fixed anchor point as the patient's position changes. Side rails seem convenient because they are near the patient's wrist, but they move independently when raised or lowered. A restraint tied to a side rail that is then lowered pulls the arm downward and outward, risking shoulder dislocation, wrist injury, and potentially fatal entrapment between the rail and the mattress. Beyond the tie point, safe restraint application requires a physician order, a quick release knot for emergencies, confirmed 2-finger slack under the cuff to protect circulation, and documented circulation and skin checks every 2 hours per facility protocol. The rule is not arbitrary. The movable frame travels with the patient through every position change, eliminating variable tension on the wrist. Understanding the mechanical reason behind the rule makes it reliable in any clinical scenario you encounter on the exam. Question 50. A PCT needs pulse oximetry on a patient with an arterial line in the left wrist, an IV in the right hand, and a blood pressure cuff cycling on the right upper arm. Which placement is the best choice for the SpO2 probe finger? Your options are A. Any finger on the right hand, B. Finger off cuff and line side, C. Any finger on the left hand, D. Same hand as the arterial line. Take a second. Which answer would you pick? The correct answer is B. Finger off cuff and line side. B is correct because a pulse oximeter probe must be placed where blood flow is steady and unrestricted. Lines, cuffs, and arterial sites all distort the waveform, so a finger uninvolved with these is required for accuracy. A is wrong because right-hand fingers are the wrong choice, because the IV in the right hand can cause swelling, and the cuff cycling on the right arm interrupts blood flow during each inflation period. C is wrong because left-hand fingers are also unsuitable, since an arterial line at the left wrist alters the pulsatile waveform that the probe relies on, producing falsely high or low oximetry readings. D is wrong because same hand as the arterial line is wrong because the line itself disturbs the pulsatile signal at the wrist and will produce unreliable saturation values that misrepresent the patient's status. Pulse oximetry works by detecting how oxygenated and deoxygenated hemoglobin absorb red and infrared light differently. The key requirement is pulsatile arterial blood flow at the probe site. Without it, the device cannot distinguish arterial from venous blood and the reading becomes unreliable. The probe emits 2 wavelengths of light through a tissue bed. Oxygenated hemoglobin absorbs more infrared light, while deoxygenated hemoglobin absorbs more red light. The ratio of those absorption signals is fed into a calibration algorithm to calculate and display SpO2. 3 devices commonly interfere with the pulsatile signal. An arterial line distorts the local pressure waveform. An intravenous line causes compression or edema that reduces pulsatile flow. A blood pressure cuff intermittently occludes arterial inflow upstream, creating signal loss or falsely low readings during inflation. Correct placement requires a site free from all three influences at once. Partial avoidance is the exam trap. A right-hand finger avoids the arterial line but stays downstream of the cuff and RV. When no finger is fully clean, a toe on the lower extremity avoids all upper extremity hardware entirely. Always ask whether anything at or upstream from the probe site could distort pulsatile flow. Nail polish causes optical interference and is sold by repositioning to a clear digit. But vascular access interference is hemodynamic and requires choosing a different limb entirely.
You have reached the end of our study video for the free complete exam preparation. Visit our website link in the description, and you can find thousands of practice questions and comprehensive study guides on our website. Thank you for studying with us today. See you in the next video.